All right, let's talk about hematology. This is the order of the videos. We're going to be doing a quick intro, then talking about primary and secondary hemostasis, the bleeding disorders, the clotting medications, and then the three types of anemias. All right, obviously everything that we're going to be doing is pretty much about blood clots, at least for the first 75% of all these the videos. So we have a break in the vessel wall. How do we repair it? How do we clot it? Why might we even need clotting? Well, obviously, if you're bleeding your extremities, or if you have an aneurysm, a break in the vessels in your brain, or you have colorectal cancer and you're bleeding, you want to clot this. You want to preserve precious resources, prevent infections. Clotting is useful for a million different things. First line of defense for clotting is vasoconstriction. So whenever there's damage to the vessel wall, endothelins will be released. This will cause vasoconstriction so that you can deviate blood away from the damaged site. Next, we have clotting. So there's two components to clotting, also known as hemostasis, also known as thrombus formation. The platelet plug is the primary hemostasis, and then the coagulation cascade with the many protein clotting factors is secondary hemostasis. So combination of these platelet here and the fibrin via the coagulation cascade makes the full clot. So there's a difference between the levels at which platelets versus the coagulation cascade is going to clot. Platelets is going to be a little bit more superficial, while coagulation proteins are going to be for deeper bleeding. And this kind of makes sense if you think that platelets are the primary hemostasis. Well, for a really superficial cut, you don't really need to call for backup. I mean, it's not that intense, and so platelets will suffice. And there's a measure of superficial platelet effects. This is going to be the bleeding time. So we can make a small cut in the arm and then just see how long it takes for the bleeding to stop. So this is going to be bleeding of the gums, mucosal bleeding, petechia, and purpura, which is for the most part just red blood cells extravasating into the skin, nosebleeds. And yeah, so anytime you see anything like that, think platelets. Now, if you see a deeper bleeding in the joints especially, you can think things like hemophilia and coagulation cascade disorders. Hopefully, eventually, we get the clot. That's great. We preserve our resources, our blood, but eventually we want this clot to go away. So this is where we're going to have plasmin break down the fibrin mesh, and the platelets will dissolve and go away. And so just a quick summary, even in the beginning intro. Step 1, vasoconstriction. Step 2, primary hemostasis with the platelets. Step 3, secondary hemostasis with the coagulation proteins. And then the last step is going to be dissolving the clot with TPA and activating things like plasmin. So there's a delicate balance between too much clotting and not enough clotting. This is really similar to what we see with the immune system, where you want your immune system to be, really hardcore and vigilant at defending you against pathogens. But if it's too zealous, you might develop an autoimmune disorder. If it's not effective enough, you could get an infection. And the same thing here is we have this trade-off between overzealous clotting and then not effective enough clotting, which would be just massive hemorrhaging. So you can develop clots if you have overzealous primary or secondary hemostasis or diminished fibrinolysis. These clots can be arterial. They can also be in the venous system. So the actual clot itself is called a thrombus, but if some of that breaks off and then travels through your circulatory system, that is now an embolus. Common ways that you might see this is a deep vein thrombosis, so in the deep veins in your legs. Often these will break off and then move to your lungs where they can get trapped, and this would be a pulmonary embolism. If they go to the brain, this is a stroke, and if they go to the coronary vessels, this is a myocardial infarction. All right, the first step in blood clotting is called primary hemostasis, and this consists of the platelet plug. Later down the road, the next step will be secondary hemostasis, which has to do with the coagulation clotting factors. And again, platelets has more to do with the superficial cuts and the bleeding time, while the coagulation factors has to do with the the deeper joint bleeds. So we get a break, and our first line of defense is these platelets, which will basically seal off the area, and they'll accumulate, and then we can even see this purple stuff in here that's layered on top is the fibrin mesh, the secondary hemostasis. So how does all of this work? Platelets are small fragmented cells from really just exploded or degranulated megakaryocytes. So in the same way that EPO, erythropoietin, causes red blood cell production, thrombopoietin from the liver helps regulate platelet production. Platelets are normally active, just floating through the blood, but they are activated by the subendothelial layer. This would be indicative of an injury. Obviously, the endothelial layer should usually seal off the vessels, so you'd only have access if there's trauma. They can be activated initially by this, but then once platelets become activated, they start to activate other platelets in a positive feedback mechanism. There are 3 steps overall to the activation of a platelet plug. One is adhesion. So 2 and 3, these kind of happen more or less at the same time, but they're going to secrete various signaling molecules which will initiate positive feedback, activating platelets, which activate platelets, which activate platelets, and then they will bind together the aggregation. So they will adhere, they will secrete things, and then they will aggregate, happening more or less at the same time. Von Willebrand factor, this is going to be an important molecule both for platelets and the coagulation factors. This is made by endothelial cells and stored in Weibel Palade bodies. So we saw this with neutrophil migration. This is where the rolling came into play with P-selectins, but this also now stores von Willebrand factor. It's also made by megakaryocytes, which make platelets, so it's going to be stored in alpha granules and platelets. So von Willebrand factor is both in Weibel Palade bodies, also in alpha granules. And they are going to degranulate upon vascular injury, spilling this von Willebrand factor into the vessels. Von Willebrand factor binds factor VIII, more on this later, but it also binds to platelets, to the damaged endothelium. This is effectively the adhesion process. Later down the road, we'll also see it play a role in platelet aggregation. So it does a lot of different things. It's a really important player in hematology. So a couple proteins that are important for platelet activation: GP1, GP2, and GP3. All of this is more or less chronological. So starting with GP1, so here's our endothelial cells. If we have a break shown here, the subendothelial layer, the platelets will be able to bind to the von Willebrand factor here, adhering them to the damaged site. Again, this is just a zoomed in version, the platelets binding to the von Willebrand factor at GP1. So then the next step, again, kind of at the same time as secretion, is the aggregation. So GP2 and GP3. So there's something called inside-out signaling. So we always have these GP2 and GP3 proteins, but they're effectively turned off. But various signaling molecules can basically, through gene expression, we can signal outwards to these proteins, activating them, exposing them so that they can bind to other GP2, GP3, causing a clumping effect. So this would be an inactive platelet. Notice it still has its GP2 and GP3. They just haven't been activated. Things like ADP, thromboxane, and thrombin will activate them. Now, they don't necessarily bind directly to one another, but using fibrinogen as a mediator, they can bind each to fibrinogen, which will bind them to one another. Sometimes, though, they can use von Willebrand factor to also bind to one another, but usually it's going to be fibrinogen. So just to recap at least the role of von Willebrand factor in platelet activation, the subendothelial layer, so here's my endothelium, so this would be sub. Von Willebrand factor will bind to GP1, and then that is the adhesion component, but then the aggregation component is that von Willebrand factor or fibrinogen, usually fibrinogen, will be the factor which binds the GP2 and GP3 from one platelet to another platelet. So the secretion component, yes, platelets are activated by the subendothelial collagen and the von Willebrand factor, but I would say that the brunt of the activation is gone ahead and triggered by various secreted substances, usually from other platelets themselves. And so this is just classic positive feedback. Platelets are secreting substance, which are activating other platelets, which will then secrete more substances. There's 2 granules inside of platelets. We have dense granules and alpha granules. So The alpha granules, I'll always think of like alpha like an alpha male, somebody being large. These are going to have the larger biomolecules like fibrinogen, von Willebrand factor, platelet factor 4, all of these large proteins. Platelet factor 4, this is important. This is something that complexes with heparin, which we'll talk more about later. So heparin is a drug, and heparin combined with platelet factor 4 can precipitate an autoimmune reaction. This is called heparin-induced thrombocytopenia. Effectively, we're going to activate all of our platelets at once and cause a thrombocytopenia. It just means that we have a low platelet count now. Then looking at the dense granules, these are going to store, something's dense, it's going to be relatively small. And so the smaller things like ADP, calcium, and serotonin. ADP is released by damaged red blood cells, so it would make sense that this should activate. If you have damaged red blood cells, that's a sign that you probably have trauma, which means you probably want your platelets to be active. So these will bind to P2Y receptors, which are G protein coupled receptor inhibitors. And if you recall, a G protein coupled receptor typically activates adenylate cyclase, but if it's a GPCRI, it's going to inhibit. And if it's going to inhibit, this means that we are going to lower the levels of CAMP. So low levels of CAMP are going to then cause calcium release, degranulation, and shape change, which allows for aggregation to take place. This is the inside-out signaling that we were just talking about. So another use of serotonin is that when we have this heparin-induced thrombocytopenia, shown on this next slide. So platelet factor 4 complexes with heparin. You have autoantibodies which will bind to this and then cause all of these platelets to activate, aggregating to one another. We see that one of the things that's released from the dense granules is serotonin. So to test to see whether or not heparin-induced thrombocytopenia is taking place, we can go ahead and put radioactive serotonin in. And if we detect the radioactivity of the serotonin being released, that tells us that we in fact have a hit pathology. Another thing that activates these platelets is thromboxane. So in addition to ADP release from dying red blood cells, they will also release some arachidonic acid from their membrane. So the membrane phospholipids turn into arachidonic acid with phospholipase A2. Cyclooxygenase, COX enzymes in the platelets can then turn this into thromboxane, and then the thromboxane will activate them. And we'll talk more about this later, but aspirin is it's commonly called a blood thinner. Aspirin, on the one hand, inhibits COX so that we don't get the prostaglandins, and this reduces inflammation, but it also reduces the thromboxane, which is necessarily for platelet activation, hence the anti-clotting effects of it. This is just a good summary. So here we have our platelet. It binds to the von Willebrand factor. Once we have here's our endothelial cell. So this is an exposed area. It binds to the GP1 receptor. Remember that things are chronological. That causes the platelet to adhere. A dying red blood cell might release a bunch of ADP, which can bind to the receptor. This will lower the CAMP levels, which causes degranulation of the dense granules, of the alpha granules. Similarly, red blood cells can release arachidonic acid, which through cyclooxygenase we can turn into thromboxane. That's also going to activate these things. This causes the inside-out signaling, which causes the GP2 and GP3 to turn into their active state. They don't bind directly with one another, but they will bind either through fibrinogen or von Willebrand factor, and this causes platelets to stack on platelets, which is just going to quickly seal up our vascular tree. Okay. So secondary hemostasis has to do with the coagulation cascade. This is going to typically occur after primary hemostasis with the platelets. And so we have two different pathways. We have the intrinsic pathway and the extrinsic pathway. They will both converge for the common pathway, starting with factor 10, works with factor 5 to activate thrombin, which is factor 2, which basically starts factor 1 fibrin to form a large mesh. The intrinsic pathway is 12 to 11 to 9 to 8, so it kind of is counting down. And then the extrinsic pathway has to do with factor 3, which is also known as tissue factor, activating factor 7. The intrinsic pathway is going to be activated due to exposed endothelial collagen, while the extrinsic one is trauma. But of course, trauma can cause collagen to be exposed. So it's very likely similar things that are activating both of these pathways. Coagulation proteins are mostly made by the liver. They are zymogens, so they are, for the most part, activated by endothelial damage. Technically, we always have some background level of clotting. Remember that when mast cells get activated, they release heparin. And one of the reasons they're releasing heparin is to inactivate some of the clotting factors so that more blood will flow into the potentially pathogenic area, so we can get more antibodies, more cytokines, more neutrophils in. That's just something from the last module to hopefully make a connection that we always do have some background level of clotting. So it's not binary clotting or no clotting. The activated form of these zymogens is the A form. So if we have factor X and factor XA will be the active one. So maybe initially it's the endothelial damage that's activating, but eventually, as we saw with platelets, it's going to be protein factors, coagulation factors activating other coagulation factors. This is positive feedback, kind of like in the GI enzyme cascade that you guys probably remember from the MCAT. Things like trypsin activates trypsinogen into trypsin, and pepsin activates pepsinogen into pepsin. So just classic positive feedback. The end goal of everything, again, is the fibrin mesh, which is just an insoluble cross-linked protein structure that precipitates out. This is just a picture of the zymogens, having an area that needs to be cleaved before they can become the active enzyme, which again has to do with A. And this is just a picture of the fibrin plug. So all of the players. So factor 1 is fibrin, factor 2 is thrombin, factor 3 is tissue factor, also known as thromboplastin. This activates 7. Factor 4 is just the calcium. Factor 5 is really just the wingman, the cofactor for factor 10. This is going to be part of a positive feedback scheme via thrombin. Factor 6 doesn't really exist. Factor 7 is activated by tissue factor, is the beginning of the extrinsic pathway. Recall that, just keep in mind that this has a short half-life. This will be important when we talk about warfarin. Factor 8 is part of the intrinsic pathway. This is also part of the positive feedback by thrombin. This stabilizes the von Willebrand factor. Factor 9 pairs up with factor 8. This is part of the intrinsic pathway as well. Factor 10, as we talked about, is the common link between everything, between the intrinsic and the extrinsic pathway. Factor 11 and 12, both intrinsic, and factor 11 is going to have the positive feedback via thrombin. Factor 12, that's actually not part of the positive feedback. This is stimulated by endothelial collagen. This is going to be the beginning of the domino effect that is the intrinsic pathway. So it's typically activated by contact factor, silica, negative things. And then factor 13 cross-links the fibrin together, as we will see. So the goal of everything is really just to activate factor 10. So factor 10 can be activated extrinsically via 7 and tissue factor, also known as factor 3. Now, it always requires phospholipids and calciums. The phospholipids for the extrinsic pathway come from whatever subendothelial cells were expressing the tissue factor. Well, for the intrinsic, it's 8 and 9 pairing up together. It's the phospholipids from the platelets plus calcium. So factor 10 does the rest. Again, we said that 5 is the wingman. 10 activates thrombin, which is factor 2. Thrombin activates factor 1, which is fibrin, and then the fibrin start to cross-link together. So the intrinsic pathway, it's going to be exposed collagen. It's going to be just, which is negative. Exposed collagen is negative, but it could just be any negative thing or many negative things. One thing is known as contact factor, also known as silica. And we have something called the partial thromboplastin time to measure how long it takes the intrinsic pathway to basically form a clot. And it should be about 30 seconds if everything's working normally. So I mentioned the positive feedback scheme by thrombin. So thrombin's job is mostly to activate fibrin. But, as we saw with platelets, we don't want it to clot eventually. We'll probably want it to clot right now, really quickly. So we have this positive feedback where thrombin also is going to help further activate 11, 8, and 5. Again, we're seeing that thrombin comes in and 5, 8, and 11 just to amplify the process. So how important is this? Well, just keep in mind that we have a couple different types of hemophilia. We have hemophilia A, which is for 8, we have B, which is for 9, and then we have C, which is for 11. And if you have hemophilia, bleeding is a tremendous problem. And this is largely just because you can't amplify the clotting process. So this should just really demonstrate how important it is to have this positive feedback. Factor VIII is produced in endothelial cells, and this is rare because most things, again, are made in the liver that have to do with clotting. It is stabilized by von Willebrand factor, and it is, during injury, this will be released, and can pair up with factor IX, which part of the intrinsic pathway activates factor X. Again, we have von Willebrand factor. Some of it will be subendothelial, but some of it is just floating through the bloodstream, and it is complex with factor VIII. Again, von Willebrand factor plays a role in platelet adhesion and platelet aggregation, but also has a role here in the coagulation cascade. Factor 12 is known as the Hagemann factor. This is kind of superfluous, actually, because of thrombin. Yes, it does activate 11, but if you recall, something that thrombin can do, this little arrow over here shows that it can activate 11. So we don't actually necessarily need 12. In fact, if you knock out 12, there's little physiological significance that occurs. But however, there's a tremendous diagnostic significance. So we know that the damaged surface, the subendothelial collagen, activates 12, and it's really the negative charge that activates 12. So when we do the PTT test, we are kind of mimicking the subendothelial collagen by providing a negative thing, activating 12, and that's how we can measure the PTT time. So it's really important for that. Additionally, 12 also activates kallikrein. Kallikrein will activate bradykinin. This is kind of the link between coagulation and inflammation. So this is going to mediate vasodilation and pain and increase vascular permeability, just hallmarks of inflammation. Bradykinin is degraded by angiotensin converting enzyme. So if you have angiotensin converting enzyme inhibitors, this can cause excessive vasodilation. Specifically, this can cause something called angioedema. And remember that we saw this too when we have the C1 inhibitor is also supposed to degrade bradykinin. And if we have a deficiency of that, especially if you have the deficiency there and you take ACE inhibitors, then that can especially lead to angioedema, this massive vasodilation of the face. So the extrinsic pathway is to do with tissue factor, which is known as factor 3, also known as thromboplastin, and factor 7. This should be about 10 seconds, ideally, to clotting, so it's a lot faster than the intrinsic pathway. And this is also subendothelial. So again, if you have subendothelial, this is just basically a marker that you must have some sort of trauma, and therefore clotting is probably going to be a reasonable call. Because anytime you see tissue factor, you have subendothelial break, so clotting is probably helpful. Tissue factor degrades very quickly. That's going to be important later when we talk about warfarin. It activates TAN, which again activates thrombin, which again activates fibrin. The goal of everything is we just want to take all of this fibrinogen. Anytime you see inogen, of course, it's a zymogen, and we want to cross-link it. But thrombin's not enough. We actually also have factor 13. So factor 13's job is to further cross-link. And see, we're getting these diagonal cross-links here with the factor 13 to make the fully formed fibrin mesh. All right, just to go back really quickly on PT and PTT. So PT is going to be the extrinsic. This is prothrombin time. You add tissue factor, and the PTT is going to be the contact factor. You're adding a negative thing. It could be silica, and that activates 12 to form a clot. And so many things later when we're looking at deficiencies in drugs is really just going to it's going to be essential to know inside and out PT and PTT. So if we want to do PTT here, we need to add calcium, phospholipids, and some negative contact factor or silica, while for PT, you really just need to add tissue factor. So PT is sometimes known as the INR, which is really just the patient's PT over the control PT. Obviously, normal should be 1. It might be a little bit higher, 2 or 3 if you're on warfarin. Or We talked about this. I'm not going to say it again. Bleeding time, we mentioned that this is going to be for superficial cuts because that is just measuring platelet function, because if you have a superficial cut, primary hemostasis might be sufficient. You might not need to also get a fibrin mesh involved. Something we haven't talked about is thrombin time. Here you're going to just add thrombin to some plasma in vitro and measure the time to form a clot. But because this is so far down the cascade, this is really going to inform only about factor 2 and factor 1. So a couple inhibitors, protein C and S are going to work together. This is going to inhibit factor 8 and factor 5. Then we have antithrombin 3, which can inhibit factor 10 and factor 2. And then we have tissue factor pathway inhibitor, which, as the name implies, probably just inhibits tissue factor. So antithrombin 3, this is a serpent. And just keep in mind that pretty much all of these things, we said like trypsin, like pepsin, and these are all zymogens. And there's zymogens that when they're active, they can then activate the other zymogens. That's because they are themselves proteases, which often work via a catalytic triad, which is a serine protease. So a serpin is a serine protease inhibitor. That's antithrombin 3. It's going to go ahead actually and affect a ton of different proteins here in our cascade. Most important, though, is going to be factor 10 and factor 2, maybe in the intrinsic factors a little bit later, which we'll talk about. Antithrombin 3 is activated by heparin sulfate, which, as we see many times, there's going to be a difference between healthy endothelial cells and damaged endothelial cells, and obviously subendothelial areas. And so what that means is if you have a normal healthy endothelial cell, heparin sulfate is there, and it can activate antithrombin 3, which is going to inhibit the clotting cascade system. And this picture here is just showing a normal healthy red blood cell on the left there. Notice that we have heparin sulfate, but in this picture on the right, I have some damage, and note that there is not so much heparin sulfate. And what that means is you would then probably have widespread clotting because you no longer have the heparin sulfate, so you no longer activate antithrombin 3. And this is kind of beautiful because now we need clotting. So this is where the drug heparin comes into play. Drug heparin just mimics heparin sulfate, which means it can activate antithrombin 3 and work as an anticoagulant. Again, that goes for factor 10. It can also go for factor 2, which is thrombin. Now, there is a difference. Unfractionated heparin can get both of these, while low molecular weight fractionated heparin will only go for factor 10. More on this later. Protein C and protein S, these can work together to inhibit factor 5 and factor 8. Note that protein C is in the zymogen state, while protein S does not have a zymogen state. Protein C is activated by thrombomodulin, which again, healthy endothelial cell. This is going to be just something we run into again and again. It's quite a motif. My 10th grade English teacher, Miss Flint, would be very happy I'm using the word motif. All right, protein C, normally inactive, thrombomodulin, teams up with thrombin, converts it to active protein C. And again, this can inhibit with protein S, factor 8 and factor 5. This is just going to go ahead and inhibit factor 7. To some extent, also factor 10A, but mostly factor 7. Plasmin's job is to break down the fibrin mesh. And when you break down the fiber mesh, one of the really important things that you'll see in during rotations is this idea of D-dimers. If D-dimers are in the blood, it's indicative that someone has a lot of fibrin mesh forming, which means that they probably have a clot. So you're looking at someone with a pulmonary embolism, somebody with a stroke, somebody with a myocardial infarction. Yes, these are proteins that we might find in the body, but of course we can also administer superfluous amounts of TPA, urokinase, and streptokinase just to superactivate plasmin to bust up these clots. So it doesn't just actually cleave fibrin, it also does cleave to some extent fibrinogen and other coagulation proteins. So this picture here is just, this is normal blood flow. We have a big clot, but luckily we put some TPA, which is just activating fibrin to break it down to restore normal blood flow. So again, D-dimers, because we get this little diagonal fibrin mesh, we get this D-dimer, which is indicative specifically of the fact that we had a fibrin clot. So this is just our fibrinogen, but note that plasmin will also break down just fibrinogen. So I guess the point is we have fibrinogen. I don't presumably have many clots going on right now, but I have fibrinogen in my blood. Plasmid is breaking that down in FDP. So if you went ahead and measured my blood and you saw a lot of FDPs, you would not want to jump to the conclusion that I had an MI or a stroke or something like that. This is just kind of business as normal. But if you saw a lot of D dimers, that specifically tells you I might have a stroke or an MI or something like that. Sometimes plasmin can be overactive. So if you have prostate cancer, you have extra urokinase. If there's a protein called antiplasmin, which does exactly what it sounds, it inhibits plasmin, but it's made by the liver. And if you have cirrhosis of the liver, then you don't have that. So plasmin is overactive. And in these cases, you're going to have extra fibrin degradation products, FDPs, which again, we said doesn't really tell us much, but this is just because it's breakdown fibrinogen, not the fibrin. If you break down the fibrin, you should have the D dimers, which is more specific. The PT and PTT should also go up because, again, plasmin also can break down coagulation factors. But the D dimers should be normal in most cases if you had prostate cancer or cirrhosis. Assuming that you didn't also have a clot on top of that. Okay, vitamin K. Vitamin K is necessary for gamma carboxylation of glutamate amino acid residues and various clotting factors. So that's a lot. Long story short, vitamin K is necessary for coagulation factors. It's also necessary for some coagulation inhibitors, which is kind of confusing. So here's our reduced vitamin K. It will then be oxidized, and it needs to be regenerated by epoxide reductase, and warfarin inhibits that. So long story short, warfarin is going to inhibit vitamin K regeneration, which means that our coagulation factors and some of our inhibitors will not be able to function necessarily normally. Where do we get vitamin K? The GI bacteria produce it for us. We do get a little bit from our diet as well, from green leafy vegetables, just like folate. And as we mentioned, warfarin inhibits vitamin K. Very important that the half-life for 7 is very short. So warfarin doesn't inhibit, vitamin K is necessary for coagulation factor production. So that means if I take a bunch of warfarin, that means I'm not producing new clotting factors. It doesn't mean I'm inhibiting clotting factors I have now. Point being, warfarin takes a while to kick in for the most part, because you would have to wait for your current coagulation factors to basically degrade and go away. And then it's the fact that you're not producing any new ones. Now, because 7 has the shortest half-life, that is going to be the first one affected by the lack of production. So that means that the PT is affected way more than the PTT. This is going to be in stark contrast to heparin, where the PTT is more affected. That's something we'll talk about soon when we talk a little bit more about the medications. The erythrocyte sedimentation rate. So this goes up with inflammatory conditions. Inflammatory conditions produce various proteins like C-reactive protein and fibrinogen. Extra proteins are kind of sticky and they cause the red blood cells to be glued together. This increases the viscosity, making it a little bit more syrup-like. So normally this is blood, and if we just spin it down or we wait, we see that all of the red blood cells clump to the bottom. The idea is that if you had inflammation, it would clump to the bottom maybe you wouldn't have to wait an hour. Maybe you'd have to wait 20 minutes. It would go more quickly. And so at a normal rate, this would be the sedimentation rate. But if you have inflammation, it might sediment a little bit faster. And this is just a great sum of everything. I would absolutely memorize all this. So for the extrinsic pathway, 7 gets activated by the tissue factor to make 7A. That can activate 10. 10 pairs up with 5. This together makes thrombin, which makes fibrin. Fibrin then also has to be cross-linked by 13. Wait a second, we also have an intrinsic pathway. 12 is activated by damaged surface, so subendothelial collagen. Think contact factor, think negative things, think silica. This activates 11, which activates 9. 9 pairs up with 8. Don't forget that. That also can activate 10, which does the same thing, activates thrombin, activates fibrin, which can be cross-linked. Now remember that we have this amazing positive feedback system so that thrombin can go back and specifically help push more 5. It can also upregulate 11. It can also activate 8. And that's one of the reasons that 12 was somewhat superfluous. 12 also, though, remember, goes ahead and helps out with bradykinin, which is the link with the inflammatory system. Now, we also have a couple of inhibitors. We have protein C, which is inactive until we have thrombomodulin, which makes it active protein C. That pairs up with protein S. That inhibits 8. That can also inhibit 5. On the other hand, we have antithrombin, which is activated by heparin sulfate. Heparin sulfate is going to go ahead and inhibit 10. It can also inhibit 2. Remember that if it's unfractionated heparin, it is going to do 10 and 2. But if it's the low molecular weight, it's actually just going to be 10. And then tissue factor inhibitor is, of course, just going to inhibit tissue factor, shown here. This is all really, really high yield. I think this is just absolutely essential to memorize inside and out. Cool. All right, let's talk about bleeding disorders. So these clotting disorders can be characterized in, I guess, 3 different camps. Those that have a deficient coagulation cascade, those that have a deficient platelet, and those that have some combination of the two. So let's start with the coagulation. So really this is just hemophilia and vitamin K. Von Willebrand factor kind of belongs here, but this really is the last category. This is mixed. So hemophilia, really we have A and B. To some extent C, but that one's not really important. So I think of A for 8, and then B comes after A, and what comes after 8? 9. So hemophilia A is for A, and A is for 8 and B is for 9. Because this is a coagulation issue, remember that platelets has to do with superficial things like nosebleeds and mucosal bleeds and cuts. But if you're talking about joint bleeds, you're dealing with a coagulation thing. So hemophilia will be joint bleeds. Something called desmopressin, randomly vasopressin mimic, is going to increase the von Willebrand factor and factor 8, which obviously will help for hemophilial A. Aminocaproic acid. So this is an anti-fibrolytic drug. So this is going to inhibit plasmin, which effectively just means that whatever clots you do have are going to last you a little bit longer. So this is going to kind of help compensate for the lack of intrinsic pathway. We can also go ahead and just plug in frozen plasma containing factors. So frozen plasma has lots of coagulation factors, not just 8 and 9, but this would help for both hemophilia A and hemophilia B. So there's the difference between a deficiency of factor 8 and a factor 8 antibody, which people occasionally can develop. So how would we differentiate this, right? Somebody walks in and they have all of these joint bleeds. I don't know if they have hemophilia A or if they have just antibodies to factor 8. So the way a mixing study works, it really depends on 2 important criteria. So one is realizing that only a little bit of antibody goes a long way. So just a little bit of antibody will significantly prolong the PTT. On the other hand, you don't really need, so the second point is they don't really need that many clotting factors to maintain a normal PTT. So what's going to happen is this might be my patient. So let's say the truth is that my patient has an inhibitor. They have the antibody. We mix their serum with normal serum, and the inhibitors, the little triangles, these are going to still be there. And like we said, you only need a tiny amount, a small amount of an inhibitor to inhibit everything. So this will prolong the PTT. On the other hand, let's say that the issue is that someone has hemophilia. So now they don't have any inhibitors, but just notice there's nothing there. They don't have the factor A. Now you mix this with the normal serum, and it's 50%. And our point is you only need 50% to be normal. And in reality, it's not actually that they'll have 0. They might have some. And so it's probably going to be a little bit higher than 50%. But nevertheless, you get the picture. Vitamin K deficiency, again, think of K for coagulation. Again, we said that vitamin K is needed to, it's a gamma glutamate carboxylate. And it's just necessary to produce, to activate several of the coagulation factors. Now, it affects many of them, but it's going to affect 7 the most. And that's because it has to do with the production of clotting factors. And because factor 7 is the shortest half-life, this will be the one that is first and most dramatically affected by a production inhibitor. So what could cause a deficiency of vitamin K? Well, obviously warfarin, which is inhibiting vitamin K via epoxide reductase, but also antibiotics. Antibiotics are producing a lot of our vitamin K. Newborns often just have issues with their bacteria, so that's also kind of the same thing. Their bacteria are not producing vitamin K. And maybe you have a really bad diet, but it also could be that you have celiacs, you have some absorption issues. Maybe you have a gallbladder dysfunction. Remember that A, D, E, K are all fat soluble, so we might need bile to help this be properly absorbed. And note here that yes, it is getting coagulation factors, but it's also affecting protein C and protein S. So it also is necessary for some of your coagulation inhibitors, which will come back very soon. That's going to be important. So other ways we can get clotting deficiencies is through transfusion. So if we give somebody saline or IV fluids, these don't have clotting factors, so this will just dilute the plasma and basically make the clotting factors at a lower concentration. Alternatively, if you do a blood transfusion, this is also no clotting factors, it's just red blood cells and platelets. So the treatment for this is just give somebody fresh frozen plasma. This is going to have the clotting factors. We were just talking about this with hemophilia. This is going this is, if you give someone FFP, this is just giving them coagulation factors. Another component, kind of the other side of FFP, is cryoprecipitate, which is specifically fibrinogen. Cirrhosis-induced clotting deficiency. Remember that for pretty much everything except, factor VIII, the liver is going to produce is going to be like a central player. So if you have cirrhosis, you can't produce a lot of your clotting factors. Because, again, 7 is the shortest half-life, the PT or the INR, which is just the normalized ratio of the PT, is going to be the most significantly affected. Also keep in mind that the liver makes thrombopoietin, which is necessary for megakaryocyte and platelet production. Also, if you have cirrhosis, you might develop portal hypertension. And so you're going to have this buildup of blood that's going to effectively push this blood flow back into the spleen. If you push more blood back into the spleen in the venous system, the spleen is just going to eat up and destroy more platelets. So not only are you producing less platelets if you have cirrhosis, you might be eating up more platelets because you're redirecting more blood flow over to the spleen. So that was coagulation disorders. So now looking at platelet disorders. So Bernard, I'm not sure how to pronounce this, Soulier, a GP1 receptor. Remember that this is chronological, the GP receptors of the platelets. This is going to be necessary for adherence to the subendothelium via the von Willebrand factor. Randomly makes the platelets really large. So look at these tiny things. These are platelets over here, and this is a huge platelet, almost as big as the red blood cell. And just to really emphasize this, all of the bleeding time should be up for the platelet disorders. Why? Because they're platelet disorders. The bleed time specifically just looks at superficial cut bleed times. So every single one of these, if I don't say it, just the blood time goes up. Glanzmann thrombosthenia. This is going to be GP2 and GP3. So remember, GP1 is for the adherence to the subendothelium. GP2 and GP3 are for platelets adhering to other platelets. They don't adhere directly. They adhere through fibrinogen, sometimes von Willebrand factor. Wiskott-Aldrich syndrome. So this is the WAS gene. The WAS gene is necessary for the actin cytoskeleton to function. We saw this with the immune system module. This causes the leukocytes, and again, like I said, they can't reorganize their cytoskeleton, which has various effects. Low platelet count and dysfunction. Also, the MHC and the antigen presentation doesn't work, and it causes eczema. So that's kind of a weird assembly of symptoms. That one's probably not particularly important. Much more important is idiopathic thrombocytopenic purpura. So we mentioned in the very first intro to clotting that petechia and purpura are specifically going to be superficial skin blood bleeds. We're going to see this in platelet disorders specifically. So this is idiopathic. So this is a diagnosis of exclusion for the most part. So it's thrombocytopenic, which just means you have a low platelet count. Often this is because, so it's idiopathic, but sometimes, let's just say 50% of the time, it might be because we have anti-GP2 or GP3 antibodies. So if we go ahead and tag these GP2, GP3 antibodies, usually when you have something tagged by an antibody, that just makes it so that the spleen can eat it up much more effectively. And if the spleen is eating a lot of these antibody-tagged platelets, it's going to cause splenomegaly. Treatments would be just, let's depress the immune system with steroids. You can flood somebody with IVIG, which really just means we're flooding with Ig antibodies, which will compete for the macrophage's attention in the spleen. So rather than the spleen binding to the platelet autoantibody, it'll bind to one of these antibodies. It's just a competitive inhibitor, so you're just going to have less platelet consumption. You can also just take out the spleen in refractory cases where they're not responding to steroids or IVIG. So quick word on what happens if we take the spleen out. So the bone marrow sometimes puts out red blood cells with the nucleus still in it. These are called Howell-Jolly bodies, so this is one here. Now, the bone marrow might put it out accidentally, but you know what? The spleen's really good at catching these and gobbling them up. But if we take somebody's spleen out, maybe to deal with particularly bad ITP, the bone marrow will put these out and we can't get rid of them. So we're going to see more Howell-Jolly bodies. So similar thing is instead of ITP, we now have TTP, and the T here, I for idiopathic, but here thrombotic. The one before wasn't thrombotic. It was just thrombocytopenia, meaning we had decreased platelets. But now we're also causing a thrombus on top of everything. So why are we getting a thrombus? So we have something called ADAM TS13. So it turns out that von Willebrand factor, so this gets destroyed to an autoantibody. So von Willebrand factor is typically stored as a multiper in the Weibel-Palade bodies, in the endothelial cells, and the alpha granules, and the platelets. But when it's released into the blood, ideally, so here we have it being all stuck together. ADAM TS13 is supposed to, you can see it's kind of broken up here, it's kind of broken up there. Breaking it up causes it to not aggregate so much, which means things can spread out a little bit. However, if we have these antibodies, and sometimes the antibodies might be precipitated by clopidogrel, which is a medication we'll talk about soon. Now, we can't break it up, and we see that we get this huge aggregation, and this is just a thrombus. These thrombi are going to be in small vessels. This is a syndrome called MAHA, which we'll talk about in the next slide. A couple of, I think of T for trio. You get this interesting trio of symptoms. You get a fever, renal failure, and neurological symptoms. Those are big ones to look out for. Not a lot of neurological symptoms on this exam. So if you see that, you might think TTP. Okay, so what is MAHA? So whenever we have a thrombus of a small, basically like a capillary, this is going to be MAHA. Notice that it is a micro, so that's the small blood vessel, and then hemolytic anemia because the red blood cells are going to break. So if this is let's say our blood, that's an endothelial cell and that's an endothelial cell. This red blood cell does not have a lot of room to get by. And so it cleaves against the sharpness of this platelet here and it becomes a schistocyte. So it's trying to squeeze by and it cuts off like a third of itself. And you can see these here, you can see another one there, you can see another one there. So these are schistocytes, which are just sheared red blood vessels when they're trying to go through capillaries. And anytime you have a hemolytic anemia, you have a red blood cell breaking open. Lactate dehydrogenase is going to spill out. Remember that is red blood cells do anaerobic fermentation. So they have a lot of LDH, not many things do in our body. And then haptoglobin, whenever we spill hemoglobin into the bloodstream, haptoglobin is going to bind to it and stabilize it. So that means if haptoglobin is too busy binding on a hemoglobin, the free concentration of haptoglobin is going to go down. And so this is just kind of a better picture. Here's our little thrombus and our small blood vessel, and this is trying to get by. Oops, it bumps into it, it gets a little crack, and now we have our schistocyte. So TTP was just our introduction there, but hemolytic uremic syndrome and DIC, disseminated intravascular coagulation, also are going to cause this. So anytime you see the schistocytes, think one of these three syndromes, all of which have to do with platelets. So HUS, very similar to TTP, no fever, no neurological symptoms, but the kidney is still a thing. And again, we just mentioned this, but you're also going to have MAHA. You're going to have a capillary thrombus. Now, this is precipitated by E. coli toxins. I think that's important to know. So DIC, of all of these, DIC might be the most important to clot or not to clot. And it turns out it's doing both. You have clotting in one part of the body, and because there's so much clotting in one part of the body, it's actually consuming the systemic coagulation factors, so that in the next part of the body, you actually cannot do clotting. So it's both. Fun, this is a wall of text. So disseminated, just meaning that it's spread throughout the body. Intravascular, because it's within blood vessels. And I actually don't like to think of it as coagulation, although the term is intravascular coagulation. I think of it as clotting, because clotting kind of encompasses primary and secondary hemostasis, platelets, and coagulation. So this consumes a lot of clotting factors. So one part of your body robs the other part of your body of the necessary factors. So we might have clotting in region X, which means we cannot do clotting in region Y and Z because we lack necessary factor 10 or necessary thrombin or necessary factor 7, etc. The clots typically form in microthrombi, meaning MAHA, meaning we have schistocytes. Now, what can cause DIC? Obstetric emergencies, because the amniotic fluid has tissue factor, sepsis, the toxins and cytokines, kind of like we saw with HUS, the E. coli toxins. These can activate coagulation factors, leukemia. We'll see this when we talk about Virchow's triad. Various types of cancers can produce molecules which are pro-coagulation. Rattlesnakes, randomly, their venom can precipitate coagulation. It can activate coagulation factors. And because we're consuming all of our coagulation factors, all of our platelets, pretty much all of these tests are going to be abnormal. All of our times are going to be higher. It's going to take longer to clot. We're going to have lower platelets because we're consuming them in region X. Fibrinogen is going to be all used up. And we're going to have anemia because we're destroying a lot of our red blood cells in the microvasculature. And so we're going to have schistocytes and elevated D-dimers, because it is true that, yes, we're using up a lot of our clotting factors. So we saw all of this, but nevertheless, in region X, we had a ton of clotting, and eventually that clot's going to be broken down, and that's going to give us a lot of D-dimers. So the treatment would be fresh frozen plasma to replenish the clotting factors, the red blood cells, because we had the shearing, the generation of schistocytes in the microvasculature and the MAHA, the platelets, because we said it's not coagulation, it's clotting. We're using up a lot of our platelets as well. And then we also want to replenish the fibrinogen. So we're going to go ahead and provide cryoprecipitate. So just a little summary of all of this. So ITP, TTP, and HUS. So first of all of these have to do with platelets. All of these are consuming platelets. The platelet count should go down for all of this. Now the MAHA. Remember the MAHA, this is just the thrombi in the microvasculature. This was only for TTP, HUS, and DIC. And so we have... now, if we're just looking at these two, remember that this was just we have the thrombus, which is why we're getting the schistocytes here and here, the hemolytic anemia, which is just that schistocyte is just the evidence of hemolytic anemia. But this is just with a platelet. Now in DIC, remember I like to say it's not coagulation, it's clotting, it's platelets and fibrin. So that means that we're consuming the coagulation factors exclusively in the DIC and not the other ones. That's why the PT and PTT and I guess INR are going to be elevated in the DIC specifically. And now just to differentiate these two, both of them are going to have kidney issues, but you have fever and confusion. Remember T for triad, the fever, confusion, and kidney issues. But the HUS, this is the E. coli GI illness, and this is just going to be kidney issues. Von Willebrand disease, so this is going to be kind of in both camps. This is both coagulation and this is platelets, primary and secondary hemostasis. So this is a very common bleeding disorder. To test for this, we can provide ristocetin. So ristocetin should bind von Willebrand factor. So here we have a normal individual. We add ristocetin and it binds von Willebrand factor, which kind of causes the platelets to aggregate together. However, if you are von Willebrand deficient in this bottom picture, when you add this, it doesn't really do anything, and I don't have any aggregation. So like we saw earlier, desmopressin randomly mimics vasopressin. Well, maybe that's not random, but what's random is that it increases von Willebrand factor and factor 8. Other causes, chemotherapy and leukemia can destroy the bone marrow, which means we have less megakaryocytes and we have less platelet production, cirrhosis and portal hypertension. Remember, the liver is going to go ahead and generate all of the clotting factors except for factor 8, which is made in endothelial cells. And so the clotting is going to go down. Now, that's coagulation. Now, let's talk about the platelets. We talked about this earlier, that if you have portal hypertension, you're going to redirect blood flow to the spleen, which causes the spleen to destroy the platelets. The liver's job is also to make thrombopoietin, which causes the megakaryocytes to be produced. So you're going to have less of that, less platelet production. A normal platelet count, just FYI, should be around 200 to 400,000 per milliliter. Not to be confused with, I think very important to know, which is why I mentioned here, the 5, 15, 45, the rule of 3. So red blood cells should be at about 5 million per microliter in the vasculature. Looking at hemoglobin should be 15 grams per deciliter, and the hematocrit should be about 45%. So 5 times 3 is 15, 15 times 3 is 45. All of these are more or less normal values, which is separate from, but not necessarily more important, knowing the platelet count, which should be about 200 to 400,000. Cool. Hypercoagulable states. So clotting disorders characterized by too much clotting. So typically there's going to be venous thrombi, deep vein thrombosis, and pulmonary embolism. Less common, but still very common, is arterial thrombi, which will just be something like a stroke or a heart attack, where an embolus is going to clog up a coronary artery. Virchow's triad is talking about 3 conditions which can all sort of work together to cause excess coagulation. So number 1 would be endothelial damage. Number 2 would be stasis of blood. And 3 would just be hypercoagulable states where the clotting factors and the platelets are just basically overeager. So endothelial damage, let's think about this. When the red blood cells and the endothelial cells basically die, a lot of their membrane is going to spill out. And remember that phospholipase C is going to break up a lot of those phospholipids, generate arachidonic acid, which the platelets through cyclooxygenase can convert into thromboxane, which can help activate GP2 and 3 on platelets, which causes their aggregation. Similarly, ADP is released from red blood cells. This can bind to the P2Y receptor, which is going to decrease CAMP level, which causes secretion of platelets. Then thrombomodulin is necessary to activate protein C into active protein C. This is only generated by healthy endothelial cells. So APC's job is to prevent clotting, but if you have damage, then that means you don't have this, which means you might have clotting. TPA is going to activate plasmin to break down clots, but this is only active in healthy endothelial cells. If the endothelial cells are damaged, you don't have this, which means plasmin is not activated, which means clotting can develop. Heparin sulfate we've seen is only expressed on healthy endothelial cells. This activates antithrombin 3. Similar effect to APC, this is going to inhibit clotting. But if the endothelial cells are damaged, we don't have this, which means we will have clotting. And lastly, we degranulate von Willebrand factor, both from the alpha granules in the platelets, but also in the Weibel-Palade bodies in the endothelial cells. Remember that von Willebrand factor can release factor VIII, causing coagulation. It also can bind onto GP1 of platelets, causing adhesion. It can also, in a pinch, it's usually fibrinogen, but sometimes von Willebrand factor can be the intermediary between GP2 and GP3 of 2 platelets. So both adhesion and aggregation. So adhesion to subendothelial collagen, but also aggregation between platelets. The stasis is just if you have your blood is flying through like crazy fast through your circulatory system, but if you've been sitting for a long time or other reasons that you might be static, the slower velocity of the blood means that the factors can kind of pool, and a higher likelihood that they might bump into each other and activate one another and start this positive feedback effect. Many different things can cause you to be hypercoagulable. Number 3, something like inflammation, as an example, might jumpstart this. So this is Virchow's triad. These are all examples of hypercoagulability, vascular damage, endothelial damage, and then things that might cause stasis. But we're going to go through this more in depth, so ignore these specifics. All right, so these are the ones that we're going to go through, and this is definitely good to know all of these. Starting with surgery. So if you have surgery, this kind of checks all 3 boxes on the Virchow's triad. Virchow's triad. 1, you have surgery, so someone's cutting into you, so you should have inflammation. That is going to basically lower the threshold of activation of your coagulation system, so the factors might activate. Plus, I don't know why you're having surgery, but probably before, during, and after your surgery, you're probably not moving around as much. That's the stasis. And someone's cutting into you. That's endothelial damage, which is going to affect all this fun stuff that we just talked about over there. So This checks all three boxes, so you're much more likely to develop a clot after surgery. Trauma, same thing. We get all three factors. So you get inflammation. Now after the trauma, you're probably going to be immobile, and you have endothelial damage, breaking a bone or opening a wound. So in a vignette, you're looking for somebody who had a surgery a week ago and then like randomly they're having trouble breathing. Maybe that's a pulmonary embolism, or somebody got into a car accident yesterday and maybe now they're a little dizzy. That could be a stroke. So that's the way that you're going to try to interpret this in a question. Travel is a big one. They're going to say, someone was on a plane like 2 weeks ago or maybe a couple days ago and now they have a pain in their leg. Well, that's a deep vein thrombosis. Malignancy, all three factors. They are, if you have cancer, you're probably not feeling great. So, maybe you're having chemo or surgery, so you're not moving during or after. The surgery can damage your endothelium. Chemotherapy, the tumor itself can damage the endothelium. Probably the biggest one, though, is that you're hypercoagulable because tumors are going to secrete various protein substances which are going to activate various coagulation factors. We don't need to know the specifics there, but just know that tumors release substances that activate coagulation factors. Next one. All right, pregnancy. So this probably evolved as a mechanism to prevent blood loss at delivery, and it works by two mechanisms. One, stasis of blood. There's less venous return due to the fetal obstruction, and so that causes the pooling, which makes clotting more likely. At the same time, you are hypercoagulable. The increased levels of estrogen are going to increase clotting factor production and decrease inhibitor production. Now, specifically, pregnant women are likely to get deep vein thrombosis, which may progress to a pulmonary embolism. So DVTs are actually very likely to progress to pulmonary embolisms, not just in pregnancy, but just period. But pregnant people, this is the more likely is that it's DVT and or PE. Oral contraceptive pills. So in that last one, we just said that increasing estrogen. So birth control is really often just a whole bunch of estrogen rolled up into a little pill. So this is going to increase coagulation factors and decrease the anticoagulation factors. Elevated homocysteine, this one's a little random. So causes endothelial injury, check. Activates the coagulation factors, check. Why might you have elevated homocysteine? So you guys cannot escape this ever. This graph is going to come back and haunt you for the rest of your life. Here's homocysteine, in the red. Now, to get this to methionine, I need B12. So if I have a B12 deficiency, this is going to go up. Now, to get it to methionine, yes, I need B12, but you also need folic acid to activate for the B12 to work off of. So if you have a folic acid folate deficiency, it's going to go up. On the other hand, homocysteine can be converted into cysteine. That needs vitamin B6. So if you have a B6 deficiency, or if you have a cystathione beta synthase, this enzyme deficiency, that also might cause it to go up. Nephrotic syndrome, you guys will learn more about this in the renal system, so I'll spare you. Basically, you have issues with your glomerulus, and you're going to lose proteins in the urine. One protein especially that you lose is antithrombin 3, and if you lose this, you're going to have excess coagulation. Smoking, I don't know if they really truly understand all of the mechanisms here, but fibrinogen levels increasing is a big one, so that's going to make you more coagulable. So now the inherited disorders. We're looking at these four. Factor 5, remember, is the wingman, the cofactor for factor 10 to activate prothrombin, which is factor 2 into thrombin. But it's called Leiden when it's mutated. So factor 5 is often inhibited by activated protein C. But basically, the mutated factor 5, called the Leiden factor, is just resistant to APC trying to turn it off, which means you're going to have extra coagulation. I think of like Leiden is in the Netherlands, and there's a bunch of Caucasian. So basically, this Leiden mutation is more likely in Caucasians over other ethnic groups. David Bloom in like 2003, I think he was a reporter for the Iraq War, and he just was kind of like a healthy, fit guy. And he died because he had maybe a pulmonary embolism or something. And it just brought a lot of awareness to this particular Leiden mutation and deep vein thrombosis. And he part of it was he was hypercoagulable because he had the Leiden mutation, but he's also sitting in a tank, and in these tiny little armored vehicles for, hours and hours and hours every day. And so I think he left the tank at some point because his leg was cramping up, just because it hurt so bad he needed to walk around. But then of course so he exposed himself to gunfire. That's how bad it hurt in his leg. And then he went back in, and then like a day later, well, the cramp in his leg was the deep vein thrombosis, and I went to his lungs, and he had a pulmonary embolism, and he died. But he's white, and the Netherlands are white, and so that's how I remember that the Leiden mutation is more likely to be found in Caucasians. So I would know it's a point mutation, and it causes an arginine to be converted into a glutamine. And again, that makes it resistant to degradation by APC, which teams up with protein S to inhibit it normally. A prothrombin mutation, you just got more of this. You got excess prothrombin, makes coagulation more likely. If you're heterozygous, meaning you've got one copy, you're going to have more. But if you're homozygous, you're going to have way more. So clotting is going to be an even larger issue. We've already talked about antithrombin 3, but let's just take another crack at it. So you might lose this because of a genetic inheritance, but it might also be nephrotic syndrome like we just talked about. So you're just peeing a lot of it out in the urine. How does antithrombin 3 work? It's activated by heparin sulfate, which is on healthy endothelial cells. That activates it. It then can inhibit factor 10 and factor 2. Heparin is going to look and work just like heparin sulfate. But if you have an antithrombin 3 deficiency, you just won't respond to heparin. So that's sometimes actually how it's diagnosed, is you're in the hospital and we're giving you heparin IV and it's just not doing anything. And then we find out, oh crap, you actually just don't have antithrombin 3. You have a much smaller amount of it. Protein C and protein S, so this inhibits 5 and 8. Again, notice a lot of this stuff is really easier if you just know the basic essentials for the coagulation cascade. So before you go ahead and learn these diseases and the hypercoagulable states and the bleeding states, just know how platelets work, know how coagulation factors work. It will be a much better investment for your time. So obviously, if you're deficient here, these are inhibitors of the system, you're going to have excess coagulation. So the important new bit of information here is that protein C, so warfarin, we know warfarin because it inhibits vitamin K. And we know, okay, vitamin K is necessary for coagulation factors. Yes, that's true, but there's a weird thing, that there's also a prothrombotic effect to warfarin. Warfarin also inhibits protein C and protein S. And protein C, so if you inhibit vitamin K and vitamin K is necessary to activate protein C, that means you're inhibiting protein C. That may be a prothrombotic effect. Now, this is going to be especially the case if you have a protein C deficiency, because you're already low on protein C. You take warfarin. Protein C has a short half-life, so like factor 7, it's very quickly affected. You get tons of coagulation in the first couple of days. This presents as something called warfarin skin necrosis, which is quite ugly. This is warfarin skin necrosis. So for this reason, people are monitored, their PT and their INR when they're on warfarin for this specific reason. So again, you might have this to some extent, but the warfarin effect is going to be much more likely if someone's protein C deficient. Antiphospholipid syndrome, so people develop antibodies to phospholipids in their vasculature, common in people with lupus. And I would know that it's frequent miscarriages. If they talk about a woman who's had several miscarriages, think antiphospholipid syndrome. And that's because it causes a thrombosis in the uterine wall, so that the baby is basically starved of nutrients. A lot of antibodies, 3 different ones. So anticardiolipin, this is important it's a false positive for syphilis. The lupus anticoagulant. This will interfere with the intrinsic PTT test. This causes an elevation when it shouldn't be. And now we can determine this through a mixing assay, which we'll talk about. So the other 2 can be determined through ELISA, but the lupus anticoagulant, more important, can be determined through a mixing assay. Know that anti-B2 glycoprotein is a thing, but there's no real superlatives about it. Diagnosing somebody with antiphospholipid syndrome, you need one of these 3 antibodies, but you also need a clinical symptom as well. So you either need a thrombosis or somebody who's just lost a lot of, had a lot of miscarriages. So let's talk about the mixing study. This is kind of like the hemophilia factor 8 inhibitor that we talked about earlier. So the PTT, we take someone's plasma, we add calcium, we add an activator. What's an activator? It activates factor 12. Factor 12, if you recall, is activated by exposed collagen, which is negative. So we're looking for something with a negative charge, sometimes called contact factor. Silica has negative charge. All of this will just activate factor 12, which is going to activate the intrinsic pathway, which is the PTT. Now, the lupus anticoagulant, again, it's an antibody that is going to bind to phospholipids. It inhibits the phospholipids, so it is going to basically mess with this whole intrinsic pathway, which would elevate the PTT. But again, this is an artifact. This is it's just not giving us a real picture about how well the intrinsic pathway is actually working. So how can we determine if somebody, in fact, has one of these inhibitors? It's the same thing we saw with the hemophilia thing. A small amount of an inhibitor goes a long way. So if someone has antiphospholipid syndrome, they have the inhibitor, you mix them with normal serum, and now the inhibitor is still there. Just a little bit of inhibitor is going to do its job. It's going to prolong the PTT. And if you had something like hemophilia, where the issue is not an inhibitor, it's a deficiency of a coagulation factor, well, you really don't need that many clotting factors to have a normal PTT. So if you mix these two together, yeah, sure, you have a lot of less coagulation factors, but you don't really need that much, and there's no inhibitors, so the PTT would be normal. So this would be a way of differentiating an inhibitor of coagulation versus a deficiency of coagulation. So when might we go ahead and investigate whether or not somebody has, these antibodies or these genetic syndromes? If you have somebody who just randomly, they're young and they have a DVT or pulmonary embolism or a stroke or an MI for no good reason, you might go ahead and do some genetic tests on them for deficiencies in AT3 or protein CNS. The Leiden gene, which is resistant to degradation by activated protein C, heterozygous or homozygous for prothrombin, or the antibodies for phospholipids, also a cancer screening. Now this is controversial, maybe not for the cancer screening, but it's expensive, and a lot of these people are already on blood thinners, which is just confounds it. Which why do the test if we don't even have that much faith in the test? Also, what's the solution? We're just going to put you on a blood thinner for the rest of your life? I guess maybe, but that's not ideal either. So people debate whether or not the workup is actually worth it. All right, cool. Medications next. Our clotting medications fall pretty neatly into three groups: antiplatelet drugs, anticoagulants, and thrombolytics. I would note that the GP2/3, the heparin, and the thrombolytics are much faster acting. They're often going to be IV drugs, and so someone with an acute MI or a stroke in the emergency room is going to be probably treated with these. The other ones are going to be a little bit more on the prophylactic side. All of these are probably going to have bleeding as a major side effect, which sort of makes sense. If you're trying to inhibit clotting, well, then there's going to be a trade-off where bleeding is going to be more likely. Let's talk about antiplatelet. So recall that thromboxane, which is generated from arachidonic acid from the membrane of endothelial cells and red blood cells, can be converted via the cyclooxygenase and the thromboxane. Dying red blood cells can release ADP. ADP will bind to a P2Y, which can cause inside-out signaling, which is going to cause granule secretion and can lower CAMP levels, which is going to also facilitate activation of the G2P. The GP2 and GP3 receptors, which are going to cause aggregation of platelets. Whew, that's a mouthful. All right, let's start with aspirin. So arachidonic acid can make prostaglandins. Well, we know this from inflammation. You've probably also heard that this affects with the GI mucosa, right? If you take Advil every night for a year, you're going to have a bad stomach. But then thromboxanes, this is part of platelet activation. So aspirin is, the other NSAIDs are reversible. This is irreversible. So this is sometimes used acutely for stroke, chest pain and heart attacks. But it's also used as secondary prevention. Now, aspirin specifically is contraindicated in kids. It can cause them to develop something called Reye syndrome, which causes jaundice and liver failure and encephalopathy. The only exception if someone has a Kawasaki's disease, which is a type of vasculitis. It can also induce asthma, and so various people have mild allergies to aspirin as well. All right, so our P2Y blockers. So remember the ADP receptor is P2Y, and binding to ADP can cause CAMP levels to go down, which causes secretion and activation of G2P and GP3, et cetera. So if we don't want any of this to happen, we can go ahead and block the binding via these 4 various medications. Note, though, that these, at least 3 of these 4, can cause antibodies to ADAM-TS13, which we previously said can cause TTP and MAHA and micro angiogenic hemolytic anemia and schistocytes. And I would note that ticagrelor does not cause these antibodies. It does cause shortness of breath, though. All right, PD inhibitors. So we just saw that when ADP binds to P2Y, it can lower the levels of CAMP. So low levels of CAMP activate platelets. So if we want the platelets not to be active, we want to raise the levels of CAMP. Remember that when we're looking at a G protein coupled receptor, adenylate cyclase helps make CAMP. CAMP is then broken down via phosphodiesterase. It's converted back into AMP. So if I inhibit this, I'm going to cause CAMP levels to go up because this is breaking down CAMP. And the CAMP levels being high is going to turn off platelets. So this is all turning off platelets. I would note that these 2 drugs are also going to cause vasodilation too, because the higher level in CAMP is also going to be present in smooth muscle. And the vascular smooth muscle, when it's relaxing, is going to cause vasodilation. So this more blood going in your head can cause headaches, can cause flushings, and the vasodilation, think Boyle's law, volume up, pressure down, it can cause hypotension. So then the G2P and GP3. So it was kind of like the flow of events is more or less ADP binds, to the P2Y. This lowers the level of CAMP. So this is kind of like first, let's block this. And then we thought, okay, well, let's then cause the CAMP levels to go up. And if we can't, at the end of the downstream effect is the G2P, GP3 receptors are being activated. And, this is our inactive state. But when they're active, they can bind fibrinogen, which means they can bind to each other. And this is causing the platelet aggregation, which is the primary hemostasis. So these drugs here are blocking this. This blocks platelet aggregation. I mentioned earlier that these are IV drugs, so these are going to be a little bit more quicker acting, and you would have this in a hospital setting rather than prophylactic. Thrombocytopenia, though, is an important side effect for these. So this is just a summary. Feel free to pause and feast your eyes on this lovely slide. All right, let's talk about anticoagulants. So just a refresher, we have the intrinsic pathway. 12 to 11 to 9 pairs with 8, that activates 10. We also have then the extrinsic pathway, 7 pairs with tissue factor, also known as thromboplastin, also known as factor 2. That activates factor 10 with the help of its trusty cofactor, wingman cofactor 5 and calcium and the phospholipids. It can convert prothrombin into thrombin, factor 2. This is going to activate the fibrin clot. With the help of factor 13, we can do the cross-linked, which is why this is a D-dimer, is different than a fibrin degradation product. Here we have the thromboplastin partial time. This is the PTT. This should be about 30 seconds. This is activated by negative things. And then we have the prothrombin time, PT. This should be about 10 seconds. This is activated by tissue factor. All right, heparin. Heparin sulfate is, so we've seen this picture before, a normal healthy endothelial cell is expressing heparin sulfate facing towards the plasma. This will bind to and activate antithrombin 3, which is then going to inhibit clotting. This makes sense because in a normal healthy vasculature, I want to keep clotting at bay. So this is a good state of affairs. But suddenly I screw up and I damage all of my endothelial cells. And what do you know? I lose a lot of my heparin sulfate due to the damage. And so now antithrombin 3 is not activated, which means it can't inhibit clotting, which means clotting happens, which makes sense. I kind of want clotting if I just suddenly had a bunch of my endothelial cells damaged. So how does heparin work? Heparin just mimics heparin sulfate. Go figure. And this is, this can be prophylactic. There's different ways we can use this, but mostly I would say this is an acute management of stroke, myocardial infarction, pulmonary embolism in a hospital setting. It is specifically going to work by, I guess maybe we'll see this. Yeah, it inhibits tons of coagulation factors. We'll come back to that in a second. I just wanted to point out that we've seen heparin be released from mast cells. So we know that mast cells release histamine, which causes inflammatory response due to allergies, stuff like that. But one of the things that mast cells releases is also histamine. And I mentioned this in a previous module. this is necessary during inflammation, because in inflammation, we want blood flow into the site of potential infection, because we want to bring in complements and cytokines and neutrophils like that. So we want more blood flow. So releasing histamine actually is kind of a smart move. And so this is just a tie into the inflammation section. So back to heparin. So this antithrombin 3 is going to be activated by heparin sulfate, or the medication heparin, or the heparin released by the mast cells. And it deals with all of these fun things, but it deals a little bit more with the intrinsic factors, or sorry, the intrinsic pathway. It does deal with 7, but in a way that I don't fully understand. 7 has a way to block the effects of heparin. So this is less relevant for the factor 7, which means, what am I blabbering on about? Heparin is going to be measured via PTT, and that's really important. So I'm going to say that again. Heparin is PTT. Warfarin is really important as well. Warfarin is going to be PT. So warfarin is PT, heparin is PTT, and except maybe at super high doses, which we can probably ignore. It does also inhibit factor 10 and thrombin, but so because it inhibits thrombin, the thrombin time is going to be affected, at least for unfractionated, which we'll get to in a hot second. So some side effects. So you can have type 1 thrombocytopenia induced by heparin. This is just going to be a mild 10% drop in platelets. Causes the spleen to take up extra platelets somehow. I don't really understand. But then we have an immune-mediated, the more important one. This is where platelet factor 4, remember this is in an alpha granule, complexes with heparin, an antibody binds to the complex, and then it activates a bunch of platelets. Activating the platelets causes them to be consumed, so that's where we get the thrombocytopenia, but it can also cause clotting as well. This would be a type 2 hypersensitivity. So here's a platelet factor 4, here's our heparin, and here's our antibodies that bind to them. To see whether or not someone has heparin-induced thrombocytopenia, I mentioned that. So one of the things in the dense granules, as opposed to alpha granules of the platelets, that can be released is serotonin. Smart scientists and doctors took advantage of this. We can have radioactive serotonin basically put into the system, so that when and if these platelets are activated by the heparin, they should release a lot of the serotonin, which is radioactive, and we can measure that, and we can say, aha, it turns out you did have this reaction to the heparin. Fractionated versus unfractionated. Long story short, the low molecular weight only affects 10, while the unfractionated affects 10 and thrombin. So here again, we see that this one is just 10. And this is just that it is less likely to induce the thrombocytopenia, the HIT type 2, and it's also easier to dose the low molecular weight one. So if let's say you're giving someone, you're doing a surgery, you don't want them to clot when you're doing surgery, so you might administer heparin. However, when the surgery is done, you want everything to go back to the status quo, so you want to reverse the effects of heparin, so you can go ahead and give them protamine, which just binds to the heparin and neutralizes it. All right, warfarin, we've talked about this. This is a vitamin K antagonist. Now, this is necessary for coagulation factor activation, specifically gamma carboxylation on glutamate amino acid residue. So to make coagulation factors, yes, we need this. We use the PT time to measure this because it's not inhibiting coagulation factors, it's inhibiting the production of them. And who has the shortest half-life is factor 7. Factor 7 is the extrinsic pathway that is PT time and not the PTT time. Warfarin is more going to be prophylactic as opposed to heparin, which will probably be a little bit more in an acute setting. A lot. All right. It doesn't directly inhibit vitamin K, but when vitamin K is going to help, carboxylate a lot of these, it sort of gets used up and it needs to be regenerated. It gets regenerated by epoxide reductase. Not if warfarin has anything to do with it. It inhibits epoxide reductase, and so we cannot regenerate vitamin K, so we cannot activate these coagulation factors. As I mentioned, it's the production of these factors, so it takes a few days. So there's a day lag for it to kick in. Now, when you administer warfarin, you have to closely monitor the PT-INR. This is for 2 reasons. Again, the PT, not the PTT, because 7 has the shortest half-life, so that's the one that's most affected. First of all, the dose is going to be difficult because it's going to vary from person to person. How much vitamin K is your intake? Are you taking antibiotics? Is that depleting your GI bacteria, which makes a lot of the vitamin K, et cetera? Probably more importantly, some people are just, as we've seen, have a genetic protein C deficiency. And now vitamin K also, yes, it does a lot of the clotting factors. It activates them. It also activates the clotting inhibitors, protein C and protein S. And yes, factor 7 is a short half-life, but so does protein C. So what does this mean? This means if you give warfarin, warfarin will stop the production of protein C. And if you're already low on protein C, then because of the short half-life, very quickly you're going to get to a point where you're way, way, way low in protein C, which means you're not inhibiting coagulation, which means you have massive coagulation. And this is something called warfarin skin necrosis, which is absolutely awful. I mean, look at that. That looks no fun. And so that's just something we need to look out for. All right, so now the simpler ones, directly inhibiting factor 10, we have these lovely things. Because it's factor 10, it's going to be part of the intrinsic and extrinsic. It's going to be both of these. Again, this is not stuff you guys should memorize. You should just know the coagulation cascade well enough that if you know factor 10 is the common part, then of course it's going to be both of these. And a direct thrombin is, of course, going to affect the thrombin time in these as well. Fresh frozen plasma, this has various clotting factors. So, hemophilia A is missing factor 8, hemophilia B is inhibiting factor 9, hemophilia C is inhibiting factor 11. Well, if I give you FFP, we're really just giving you all of those. We're a little bit solving the problem. If you have von Willebrand factor disease, you can't bind and you're going to be factor 8 deficient. Now we can give you FFP and replenish that, et cetera. Also, if we give you too much warfarin, you're not going to be producing enough of these factors, and that could be an issue. So we can just give you fresh frozen plasma to deal with the overdose and sort of correct for that. On the other hand, we have something called cryoprecipitate, which specifically has fibrinogen. So somebody donates blood, and we can break it up into red blood cells, fresh frozen plasma with the coagulation factors, isolate the platelets, but then they cryoprecipitate has the fibrinogen. This is often used for DIC. Remember that this is consuming tons of coagulation factors, but it's also doing lots of clotting, at least lots of clotting in region X. Region Y might have no coagulation factors because they've all been consumed, but we'll focus on region X. Way too much coagulation, which means all of the fibrins used up, which means we really need to replace the fibrinogen. TPA, streptokinase, and urokinase, we said that these activate plasmin, so they're clot busters. Busters, not blusters. So here's our normal blood flow. We've got a thrombus or an embolus. Okay, let's give somebody TPA in an acute setting in the emergency room. That's going to come in, activate plasmin. Plasmin is going to break down this clot and restore normal blood flow. What are we going to see in this? We're going to see a lot of D dimers in this case. So I mentioned that all of these drugs are going to, exacerbate bleeding. These are going to really exacerbate bleeding, so extra effect there. And you can counteract these effects with something called aminocaproic acid and tranexamic acid. So these are activating plasmin. These are the fibrinolytics. And these, for various reasons, would be you might want to inhibit this. Let's say you have hemophilia or something. This might be useful. All right, this is a fun summary. Feel free to pause and just go to town on this one as well. All right, last section, anemias. All right, very quick segment about anemias, just as an overview. This is when you don't have enough red blood cells. Red blood cells carry oxygen, and so obviously the main feature here is you're going to feel super tired. So, like I said, you're going to feel very tired, very, very, very tired. Shortness of breath, same deal. You don't have enough oxygen going around. The red blood cells are going to, and the blood is going to generate a lot of heat, a lot of warmth, and so your extremities might be cold. Conjunctival pallor is going to be a large one, so it should be a lot more red here, and it's not. Again, not enough red blood cells. This one I never heard of. I thought someone might be messing with me. So this is apparently where you just start eating things that aren't actually food. You mistake them as food. So I'd never heard of this, but apparently that's a symptom of anemia. So treatments, we'll obviously go through the various types, but probably the main reason for anemia is just an iron deficiency. So You might want to just supplement with iron. Sometimes it might be due to a folate or a cobalamin, B9 or B12 deficiency. So you would supplement with that. Of course, this will only work in those two specific instances. Often you can just do a blood transfusion, but you should just be aware that one of the major risks of a blood transfusion is that you can potentially give somebody an iron overload. The red blood cell measurements. So rule of three, red blood cells should be 5 million per microliter. Hemoglobin should be 15 grams per deciliter, and your hematocrit should be about 45%. So 5 times 3 is 15, 15 times 3 is 45, rule of threes. So there's a lot of different things we can measure with the red blood cell index. Far and away, the most useful one is going to be the mean corpuscular volume. So if you're less than 80, it's a microcytic red blood cell. If you're 80 to 100, it's a normocytic. If you're greater than 100, it's a macrocytic. So maybe be aware of these terms, mean corpuscular hemoglobin and the hemoglobin concentration. I don't think these are as important, but you very well might see them. And this is just all of the anemia, or most of the anemias, and how we can, break them down via subclass. So we'll get into all of this in the upcoming sections. Note, of course, though, that we're breaking them into microcytic, normocytic, macrocytic. That is just far and away the best way to organize them. So let's get into it. Okay, let's talk about microcytic anemias. Look for red blood cells with a mean corpuscular volume less than 80. All of these, whether it's a thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, or sideroblastic anemia, most of these are kind of united in the sense that they really just stem from a failure to produce hemoglobin. So red blood cells have just really bags of hemoglobin. They have 2 alpha chains, 2 beta chains, and a couple of heme groups, which is a protoporphyrin ring containing iron. So we're going to get into all of these. Less hemoglobin means that it's hypochromic. What gives red its red color is the hemoglobin and how it interacts with light. So if you have less hemoglobin, you're going to have hypochromicity. So this is going to be a microcytic anemia, and this is going to be just a normal, healthy one over here. Additionally, to keep the hemoglobin to volume ratio normal, your bone marrow cranks out smaller than normal red blood cells. Or at least, we can put an asterisk, because not all the time, but typically that's what it tries to do. So you can produce less hemoglobin, and so the solution is have smaller red blood cells, and then it'll kind of fit more or less. So the ways that we can get this is we can have defects in the globin production. This will be the thalassemias. Less iron. This could just be an iron deficiency, or defective heme production. You could have an enzyme deficiency, and you could have lead poisoning. So let's start with the thalassemias. So, like I said, your hemoglobin is 2 alpha chains and 2 beta chains. Thalassemia is probably going to be most significant in people of Greek descent, Italian descent, people in the Mediterranean. It is a protective effect similar to sickle cell against malaria and plasmodium. And we have 3 main types for adults: hemoglobin A, A2, and F. Notice that alphas are in all of these. So alphas is arguably the most important then, and it's the partner then that determines the type, right? So like A is going to be because of the beta, this is going to be, A2 is going to be because of the delta, and then the fetal is going to be because of the gamma. And we'll ignore this one. And then the abnormal ones, the H and the BARTs. This will be triple thalassemia alpha, and this will be quadruple thalassemia alpha. I'll talk more about this in a hot second. So, well, the alpha chain might seem more important. I guess you could consider it more robust. Maybe this is debatable, but because we have 4 copies of it rather than 2 copies of the beta globin genes. So you can, if you lose one beta globin gene, like now you only have 50% beta globin production, but you have 4 alpha globin genes. So you could arguably lose one and you could still be okay. So 4 alpha globin, 2 beta genes. If you have a defect in an alpha gene, it's a deletion. So missing alpha gene is all or nothing. On the other hand, though, the beta genes, they very rarely get deleted. It's usually just a mutation. So it could be a variable effect then, right? Maybe it's just less transcription. Maybe the protein is made, but it's just a little bit less functional. Maybe it's not functional at all, right? It depends. So we have the B plus or B1, which is reduced functional capacity for that particular gene, and then just B naught, where either we're not having any transcription or the gene, like the protein itself, just sucks. For the alphas, again, note that you have 4. So you could have 1 defective, you could have 2 defective, you could have 3 defective, or you could have all 4 defective. Notice in the 2 defective case, it could be trans mutation, meaning that we're diploid on the mommy version, on the daddy version, you have a defects. Or it could be cis, meaning both come from the mommy version or both come from the daddy version. Interestingly, people of African descent typically have if they're thalassemia minor, meaning they have 2 defective alpha genes, they're usually on different chromosomes. They're a homologous pair. But for people of Asian descent, they're often on the same one, which is interesting. And you should know. Alpha versus beta. All right, let's just get into the details. Alpha thalassemia, 1 deletion. Sometimes this is called minima, no symptoms. 2 deletions, mild anemia. Sometimes this is called minor or trait. Like we just said, Asians would be cis on the same chromosome, while the Africans, people of African descent might have 1 on 1 chromosome and 1 on the other chromosome. If you have 3 deletions, again, alpha is going to be complete deletions. You will have severe anemia. This is where you accumulate the H, sometimes it's called H disease, and this because you have the hemoglobin H, which is really just a beta tetramer. And if you think about it, this kind of makes sense, right? The main type of hemoglobin, 97% of your hemoglobin is hemoglobin A, which is supposed to be alpha and beta. But you have 25% of normal alpha production, meaning there's just way more betas than normal. So the betas are just going to pair together, and sometimes they make these tetramers, which we call hemoglobin H. This is really bad for the red blood cells, and they're basically either going to explode on their own, or the spleen's going to notice that they're abnormal, and hemolysis will ensue. LDH increases, the spleen tries to eat them up, so you get splenomegaly, and when they spill their guts into the bloodstream, the heme gets converted to bilirubin, and so the bilirubin levels go up. You could get things like jaundice. Now, if you have 4 deletions, this is incompatible with life. Hydrops fetalis, massive edema, and heart failure for the baby. You have something called now the Bart's tetramer. So the hemoglobin H, you could be a kid or an adult and live with this. You might be sick. You might need transfusions all the time. But you have this beta tetramer. Why do we have the gamma tetramer here? It's because the gamma is produced very early on when you're 1 or 2 months old, and it eventually goes away. But so these gamma globin genes will accumulate. You probably won't even get to the point where you could form the hemoglobin H beta tetramer, or at least not a significant amount. So if that made sense to you, great. If not, it's not a big deal. Hemoglobin H for 3 deletions, the gamma for the Bart's tetramer for the 4 deletions. All right, beta thalassemia. 1 deletions, minor. 2 deletions, and I shouldn't say deletions, I should say mutations. 2 mutations would be a major anemia, sometimes called Cooley's anemia. So your body is desperately trying to crank out red blood cells that are effective. So it's doing something called extramedullary hematopoiesis. And think about this. Medulla is the bone marrow, and then hematopoiesis is the making of blood cells. So effectively, your body's trying to make red blood cells outside of the bone marrow. There's a bone marrow expansion during early development and embryogenesis that causes skeletal deformities, and not the nicest phrase, but that it's known as I guess the face kind of looks like a chipmunk face, so chipmunk faces, and sometimes they say a crew cut appearance for the skull on an X-ray. And so this is bone marrow expansion due to excess erythropoietin, because there's no negative feedback because you don't have proper red blood cells being formed. Sometimes the extramedullary hematopoiesis, will be present in the skin, so your skin will start trying to make red blood cells, and then your spleen and your liver start to try to make red blood cells. And nobody's as good as making your red blood cells as your bone marrow, so you get nucleated red blood cells sometimes when it's extramedullary. Often, whether it's a minor anemia or a major anemia for betas, you won't see it for 6 months, because you do have hemoglobin F for the fetal hemoglobin for 6 months of your life from mom until the production stops and these hemoglobin proteins start to decay. And this isn't affected by beta because the hemoglobin F is 2 alpha genes and 2 gamma genes. For the again, we're still just specifically in the major. I would note that they have crazy variety of red blood cells on a histological smear. Anisocytosis, which is a variable red blood cell width distribution. Poikilocytosis, the shapes are going to be all funky. basophilic stippling. They're going to have RNA, and then target cells. We'll see all of these, and we'll go into detail. So anisocytosis, just the red blood cell width distribution, is going to be all over the place. So you can't really see it so much right here. Let's just imagine this was a little thinner and this was a little wider. So basically, there's just more variability for the beta thalassemia major as opposed to the normal one. So yeah, they can be all sorts of shapes and sizes, and let's just focus on this. Basophilic stippling, we have these RNA fragments all over the place. Not just fragments, but they will precipitate and form these collections, which are identifiable on histological analysis. And then we get these target cells. Target cells come from like a screwed up surface area to volume ratio. So you can have a defective surface area to volume ratio with beta thalassemia major. You can also have it in situations where so here we have a decreased cell volume because we're microcytic anemia. You could also have it if you had, instead of the volume being screwed up, maybe the surface area is screwed up. The cell membrane is going to be dysfunctional if you have a liver disease due to defects and alterations in cholesterol metabolism. All right, so yeah, kind of be familiar with this. Maybe let's just focus on this one on the right here. So this would be a normal person. They have a little bit of A2, a teeny amount of F, and then mostly 97% hemoglobin A. But if you're thalassemia B minor, notice that we have a lot less A because A is going to be 2 alphas and 2 betas, and we don't have as many betas. So what we have is a little bit more of the A2 and a little bit more of the F. Now, if we go all the way to thalassemia beta major, you have almost no beta. So the hemoglobin A is almost invisible. The hemoglobin F and the hemoglobin A2 goes way up. Now, if we go to triple A, so thalassemia alpha, but it's 3 deletions, and it is deletions in the alpha versus the beta. This is where you have the H, which is going to be the beta tetramer. So here's our beta tetramer over there, hemoglobin H. Again, if it was the 4 deletions, it would be the gamma tetramer, BARTs. And then over here we have hemoglobin S. Well, this has to be sickle cell, which we'll talk about later. Okay, so thalassemia is the first way. We just don't have good, we're not making appropriate globin genes, and therefore we can't make hemoglobin. If you can't make hemoglobin, you make smaller red blood cells. Alternatively, we could have not enough iron. And remember that iron is in heme, and you need heme to make hemoglobin, so it's going to be kind of the same deal here. So how do we get iron? Sometimes we get some free iron, but most of the iron that we obtain is through meat in the form of heme. So vegetarians and vegans would be more predisposed to be iron deficient than somebody who eats a steak for every meal. I'm not advocating like a pro-meat diet at all, but just that is how it is. It is difficult to excrete iron unless you have heavy menstrual flows, or particularly important is colorectal cancer. If you have colorectal cancer, you will have blood in your stool. Often it's cryptic, meaning sometimes it's microscopic. You don't even know you're losing blood, but you're actually losing a ton of blood every bowel movement. And over time, there is the equilibrium is thrown off. You're excreting much more than you're taking in. And over the course of months or years, you become severely iron deficient. Colorectal cancer is particularly slow growing as far as cancers grow. And if you get blood transfusions, I mentioned this before, but you might throw off this equilibrium in the other direction. You might have excess iron in this case. So 2 iron-related proteins that we should know are 2 main ones. Ferritin. Ferritin stores iron. It stores this in macrophages, which is going to be in the bone and the liver. And now if you're iron deficient, well, then your stores are going to go down. So this is going to go down in that case. That kind of makes sense. You have less stores in the macrophages. We have a picture a little bit over here. Here's our bone marrow. Here is our macrophages storing it in the form of ferritin. Also in the liver, storing it. We also have a protein called ferroportin, which is going to transport it out of the cell and into the cell. Also, it's going to help us absorb through the GI tract as well. Our other protein is transferrin. So I like to think of transferrin as, imagine that, your blood sugar should be around like 100. And if the blood sugar goes down, you have glucagon, which raises it. And if the blood sugar goes up, you just had 8 brownies, then you're going to have insulin that's going to bring the sugar levels down. It's kind of a similar thing with the iron levels. We want a nice homeostasis for the iron concentration in our blood. So if we're iron deficient, iron levels in our blood go down. Transferrin is going to kind of work like glucagon. It's going to raise, in the same way that glucagon raises the blood sugar, this is going to raise the iron levels in the blood. Now, I guess the difference is glucagon doesn't actually carry sugar. This raises the iron levels of blood. It also then transfers it through the blood as well. So it's not completely analogous. I would just know that TIBC and transferrin are more or less the same thing. Total iron binding capacity. TIBC is really just transferrin for our purposes. And so if we're iron deficient, that means that the iron levels in our blood went down. We want to raise them. So the transferrin levels is going to raise the iron in our blood. Again, it's think of it like blood sugar. I think it becomes a lot easier to conceptualize. And now there's something called the percent saturation, which is really just the transferrin levels over the serum iron levels. If you are iron deficient, so here's our protoporphyrin ring. Notice that we have no iron here. So and the only difference betweme heme and that is that you have the iron. So you know what? If you're iron deficient, then this is going to go up and this is going to go down. So sometimes they'll say that your free erythrocyte protoporphyrin levels are up, and that just means that you're iron deficient, or that's one possibility. So how do you become iron deficient? So like I said, maybe you're a vegetarian, you're vegan, and you're not taking supplements, and you're, I don't know what else, whatever type of kidney bean or something has lots of iron, you're not eating that. So that might make you iron deficient. Maybe you have a bad diet and you're an alcoholic or something, and so that might cause a malnutrition. Probably more likely is malabsorption. So maybe you have celiac disease or some other duodenal issue, and that's going to cause malabsorption. If you're on a proton pump inhibitor, this is going to push iron from the Fe2 plus state into the Fe3 plus state, and the Fe3 plus state has a harder time being absorbed. So if you have lots of stomach ulcers, you take PPI, that might cause you to become iron deficient. And then the iron demand goes up in pregnant women. And so maybe you're just carrying on business as usual, eating what you normally do, exercising like you normally do, and yet the iron demand's gone up and you have not raised your burger intake or whatever, and so you might become iron deficient in that case as well. Two other scenarios where you might become iron deficient: hookworms, scary monster. These will go ahead and just scavenge a lot of your iron. It's one of the many horrible things they'll do inside of you. And then there's a rare syndrome called Plummer-Vinson syndrome, which you'll see a lot. You'll see a bit more in the GI thing in I guess like 9 months or so. Look out for a triad. So one of these, the relevant one, is that you become iron deficient. Esophageal web. So this is a healthy esophagus. And this right here is just this little thing that's kind of jutting out. That is an esophageal web. And you have a hard time swallowing as well. So Plummer-Vinson syndrome it could also lead to iron microcytic anemia. So early on, so here's our microcytic and here's our normocytic iron deficiency. So early, it's normocytic, normal size, and then later it becomes microcytic. So if they don't give you the context, I would probably just go ahead and say it's microcytic. But early on, you produce less red blood cells with, you produce less red blood cells, but they're the normal size. Eventually, you start producing less red blood cells, and they're smaller as well. So the RDW is up. So a kind of an anisocytosis. We have this, our width is up. So we saw this with beta thalassemia, also known as Cooley's anemia as well. So anemia of chronic disease. If you have an infection or if you have an autoimmune disease. So if you have an autoimmune disease, your body kind of thinks maybe that it has an infection. You're in a chronic inflammatory state. And so you're making a lot of cytokines. One that's relevant is hepcidin. And so a kind of interesting evolutionary defense mechanism is that a lot of pathogens want to come in, and it's really important that they get iron. So one of the first things they'll do if they're trying to replicate inside of you is they'll steal a lot of your iron. So as a defense mechanism, your body kind of salts the earth a little bit, and it's going to the hepcidin is going to inhibit ferroportin. And if you remember from the previous slides, ferroportin's job is to transfer iron across cell membranes and also to absorb it from the GI tract. So you're going to get less iron overall. You're basically hiding it from the, let's say, the bacteria or the parasite to starve it of iron so that it might die. And it's the same explanation as before, the fact that we see this as both a normocytic, here's our anemia of chronic disease, and it's over here as well. So initially, you might produce less red blood cells of normal size And then later there'll be less red blood cells, but they'll also just have less hemoglobin, and therefore they'll be smaller. Lead poisoning. So just look for them saying, hey, somebody was doing construction in an 80-year-old house, or some kid was licking the paint off their 80-year-old house. That's lead poisoning. That's going to come up in a vignette. Lead paint. So specifically, it will inhibit either ALA dehydratase or ferrochelatase. Also keep in mind that these steps are in the mitochondria and these steps are in the cytosol. So it doesn't inhibit it 100%. So you very well might have a buildup of ALA. So these levels might go up a little bit. Same thing with this. You're going to inhibit this, and therefore you might get a little bit of this to go up. So you might have higher levels of protoporphyrin, higher levels of ALA, and of course you're having a hard time complexing your iron with the protoporphyrin, so your iron levels might be a little bit higher as well. Things to look out for lead poisoning: abdominal pain, lead lines. So this can be called burden lines in the gums. Shown here, you can kind of see this lead deposits. And then in the bone metaphyses on x-rays, you shouldn't have this little white line here. That's lead accumulating at the metaphyses. Peripheral neuropathy, neurological defects in developing kids is particularly important. So if you have a 5-year-old kid who's having trouble talking or something, they are not, you think of the Piaget stages in the MCAT psych section. These kids are not reaching their milestones. It might be that their brain development is a little bit screwed up because of the lead that they're consuming. So as a therapy, you can chelate lead with things like EDTA, dimercaprol, and Susimer. So for basophilic stippling, so we saw this earlier in severe beta thalassemia. This is where you have the RNA remnants. So it turns out lead also inhibits this enzyme, which breaks down RNA. Therefore, you're going to have more RNA, and it's going to concentrate itself and form these little insoluble granules, basophilic stippling. Additionally, like we said, you're going to have, you can't complex the protoporphyrin with the iron to make heme, so the iron levels are going to go up, and the iron is stored in these little granules shown here. I would know if they say something is a Prussian blue stain positive, this is specifically looking for iron. You can have sideroblasts in the bone marrow, but if you have sideroblasts pushed out in the red blood or into the systemic circulation, that is a sign that there is maybe lead poisoning or something wrong with your heme synthesis pathway. So these are sideroblasts, and this is sometimes termed as sideroblastic anemia. So one cause here, so like we said that, sometimes these are nucleated red blood cells, but they have these iron granules, and outside of the bone marrow, this would be abnormal. So not enough protoporphyrin to pair with the iron. So good, we talked about that. And we said that lead poisoning makes sense. Now, what are other causes? Vitamin B6 deficiency. So maybe you're not getting enough vitamin B6 in your diet, but it's more likely that you're on like a tuberculosis medicine, like isoniazid, and this is going to inhibit and lower the levels of B6. Notice that B6 is an important cofactor for this very first step. So if you have isoniazid, you have lower B6, and therefore you can't do this first step, and that might mean that you're going to have less heme production. Alternatively, alcohol is a mitochondrial poison, and we said that all of this is in the mitochondria, and so this might also screw up this first and last step, and again, you're going to have lower heme production. You could also have ALA synthase deficiency, which is an X-linked syndrome, and so specifically this is down, and again, same thing. This would cause heme production to go down, which might cause sideroblastic anemia. Iron study. So, let's just think about iron deficiency over here. Well, you know what? It's friggin' in the name. So your serum iron levels, they're going to go down. They're low. Why? Because they're actually low. And if the iron levels are low, then you know what? You're storing less iron. So that sort of makes sense. Now remember, it's like glucose in the blood. Your iron levels in the blood are going down. Your TIBC, which is just your transferrin, its job is to raise your iron levels. It also transports it, but just think of it as it's more important. It's easier just to think it's trying to raise the iron levels. So it's trying to raise the iron levels, so this goes up. Now the percent saturation, remember that this is the iron over the TIBC, and and the iron went down and the TIBC went up. So this is going to go double down, hence the double arrows. Anemia, chronic disease. So this is low iron levels, but remember, it's not actually low. The serum level is low. That's because we're hiding it from the the monsters, the bacteria, whatever pathogen. And again, it might not actually be a pathogen. It might be that you have an autoimmune disease and you're in a chronic inflammatory state. And so the hepcidin is it's quote unquote like your body thinks that it's under attack. And so it's nevertheless hiding it. And so if it's hiding it, where is it hiding it? It's storing it in those macrophages in the bone marrow and the liver. So the ferritin level goes up. And then this is going to go down as a result. And then sideroblastic anemia, you can't use it. You cannot complex it with a protoporphyrin to make heme. So it's going to go up. The ferritin levels are going to go up. Why? Because you have more, so you've got to store more of it. And then the TIBC, this one's a little tricky. I don't think this one's important. It's the same. Sometimes people say that it might be a little bit lower, and that's because it's trying to, I'm not even really sure. Let's just say same. I don't think this one's particularly important, so I'm going to skip over that. All right, so this is a little decision tree. If we have a low heme levels, it's either lead poisoning or sideroblastic anemia due to, maybe like X-linked ALA synthase deficiency. If you have, and again, this hypochromic is also going to be very telling. Low iron, maybe you just have low iron. Maybe you have a colorectal GI bleed. Maybe you have anemia of chronic disease because you have an autoimmune condition or you have an infection. If we see that there's something wrong with your beta thing, maybe you have a thalassemia. Do you have hemoglobin H? If so, you have 3 defective alpha genes. Do you have hemoglobin BART? If so, you have 4 defective alpha genes. Do you have more A2? Do you have more F? This might be a beta thalassemia. Do you have the chipmunk facies? Do you have, what is the red blood cell distribution width like? Do you have basophilic stippling? These are all things that you're going to go ahead and evaluate when you're, making your decision. Normocytic. The normocytic anemias are characterized by a mean corpuscular volume from 80 to 100. So this is a normal size. This is what they should be. And if you think about this, these fall into 2 categories. And one is the non-hemolytic. So this is an underproduction. And then the hemolytic, this is due to premature destruction. And if you think about both of these, premature destruction or underproduction, neither of these should have any effect on the size. So it kind of makes sense that both of these would fall under the category of red blood cells, anemias that are of normal size. They're not produced enough or they die too quickly. So the non-hemolytic, where they're underproduced, this is you can characterize this with a low reticulocyte count, which we'll talk about. And then the hemolytic would be a high reticulocyte count. So what are reticulocytes? These are premature red blood cells, and it's kind of like what we saw in the immune module. You had a left shift with neutrophils. If you really, really, really needed a lot of, you needed an army really quickly, and you didn't have that many neutrophils, you would start to push out the immature, I bands, which we called a left shift. And I thought of that as like, we're at war and we really need all the men and women we can get. And so, we don't care if they're not 18, we're going to push them out when they're 11. We're just going to give them an assault rifle and say, go get them. It's kind of the same thing here. If you have a hemolytic anemia, all of your red blood cells are being killed. They're being killed. And so your body is, to counteract this, is like saying, okay, we need to just push out as many red blood cells as we can to replenish the ranks, and it gets a little bit overzealous. It pushes them out before they're ready, which is why the reticulocyte count go up. It doesn't go up here because the whole point is that this one is characterized by an underproduction, and there's a variety of reasons for why the red blood cells might be underproduced that we'll get into. So to calculate the reticulocyte value, it should normally be 1% to 2%, but it's actually difficult because this is expressed as like a percentage of the red blood cells. So you kind of switching 2 variables at once. So if the red blood cells are also down, that could be a confounding variable for your reticulocyte count. So we have a corrected reticulocyte index. And the formula for that is the patient's reticulocyte percentage multiplied by the patient's hematocrit divided by a normal hematocrit. So let's look at an example of this. Let's say the reticulocyte percent might be 5. And we go, oh, wow, that's high. It should be 1 to 2. But we then also note that the hematocrit is particularly low. And so we say, okay, 5% multiplied by the patient's hematocrit divided by the normal hematocrit. 5% times 1/2 is 2.5%. So it's actually not as high as we originally thought once we went ahead and figured out what the corrected reticulocyte index is. All right, so let's start with the non-hemolytic underproduction of red blood cells. A couple different reasons why this might happen. So iron deficiency and anemia of chronic disease. We've really already talked about this, so that'll be quick. But that's a low iron in both cases. We know whether or not you have low iron or whether or not seems like you have low iron because you're hiding it from the monsters. Aplastic anemia means your bone marrow sucks, you're not producing it. And then chronic kidney disease, CKD, means your kidneys suck and they're not producing EPO, erythropoietin, which is necessary to stimulate red blood cell production in the bone marrow. So whether it's iron deficiency or anemia of chronic disease, we say that early on, so both of these cases, not enough iron to produce heme, and therefore you're going to have less red blood cells. And early on, we said that, okay, we're fine with just less red blood cells, but at least we'll equip them with a normal amount of hemoglobin, and that's why they're normocytic. However, eventually we say, okay, we're going to have less red blood cells, but we're also going to have less hemoglobin per red blood cell as well. So that's why they fall into both camps. All right, so let's move on to the new stuff. Kidneys make erythropoietin, stimulates erythropoiesis. So this would be normal. And if you're hypoxic, you're up in the mountains, you're not getting enough oxygen, your kidneys will produce more EPO so that your bone marrow will produce more red blood cells so that you can, deliver more oxygen to your body. And obviously, blood doping and many athletes have taken EPO to gain a competitive advantage. But if your kidneys suck, then you can't produce it. All right, moving on to the next one. It's short and sweet. Aplastic anemia, aplasia, no proliferation. In this case, because you're defective stem cells in your bone marrow. And then anemia, of course, I didn't explicitly say this. Maybe I did. Anemia is a lack of red blood cells, but this is a misnomer because at least in the case of aplastic anemia, the bone marrow doesn't just make red blood cells. It makes white blood cells. It makes platelets. So it's going to affect everything, which is why this is a pancytopenia. And if we want to think about what the symptoms are, just think about what would happen. If you don't have anemia, you have pallor and fatigue, and apparently pica. You just start eating paper thinking it's potato chips. And leukopenia, no neutrophils, means you're going to be more prone to infections. And then no platelets means you're going to have more bleeding. Your clotting is not going to work as effectively. And this is just a picture of normal. We have all of these fun platelets and white blood cells and red blood cells. And here's a little bit less of everything. The bone marrow is particularly fatty. There's less hematopoietic stem cells has been replaced with fat. All right, so what can cause this? They used to call it idiopathic, but now they actually think that it might be an autoimmune T-cell response, often following hepatitis. It could be genetic, so Fanconi's syndrome is something you'll see a lot in the renal section. It has to do with kidneys. People have malformed thumbs is something to look out for. But you have defective DNA repair enzymes. So this could lead to cancer as well. But in this case, we'll just say that defective bone marrow causes aplastic anemia. Different viruses, Epstein-Barr virus, hepatitis, HIV, parvovirus, B19, which we'll come to. Benzene, I think shoe factories, rubber factories, radiation. Maybe you work at a power plant. Maybe you work dealing with the waste of a power plant, or maybe you had a cancer and you had someone give you radiation therapy. That could eradicate all of these stem cells in your bone marrow. And then many medical drugs, cancer chemotherapies, immunosuppressants, even thyroid medications can go ahead and wipe out your bone marrow, causing aplastic anemia. So the treatment, this mostly works for the idiopathic immune-related, but anti-thymocyte globulin targets the T cells, and then the immunosuppressant. But then you could just give somebody transfusions. Again, whenever you have transfusions, you should be aware of getting in more iron than your body than you can excrete. Again, it's kind of difficult to excrete iron. Bone marrow transplants, and then bone marrow stimulation, erythropoietin, granulocyte macrophage colony stimulating factor. You don't have that many cells left in your bone marrow, but if you can stimulate the few ones you have to work extra hard, maybe you can kind of offset whatever disability you have. And this slide, don't pay attention to anything here. This is just to remind you that a really common reason for this is the fact that it is secondary to medical drugs that you might have wiped out your bone marrow. All right, so that was the non-hemolytic, just the underproduction, whether or not it's just you don't have enough iron or you don't have enough EPO, or you wiped out all the cells in your bone marrow, all the stem cells. Now let's look at the hemolytic, the red blood cells that are just dying prematurely. And we can divide this into two sections, the intrinsic and the extrinsic. So intrinsic meaning there's something wrong with the red blood cell itself. The red blood cell just sucks. It's unstable and it just dies. And so that is an intrinsic cause. And if you look at all of these, a lot of these are just genetic syndromes, which might cause the red blood cells to be crappy. A lot of times a crappy red blood cell will get taken care of and eliminated by the spleen. Extrinsic is exactly what it sounds like. It's extrinsic. It's autoimmune, so it's an antibody attacking the red blood cell, or it's bumping into barriers in small vessels or large vessels, or you have an infection that kills all your red blood cells. So intrinsic versus extrinsic. Not to confuse, so we have two types of homologous, intrinsic and extrinsic, whether it's due to intrinsic or extrinsic factors, but then there's also two locations of hemolysis. Are they in the vascular, just in the blood vessel? Is the red blood cell just dying? Here's an example of the C5 to C9 complement proteins activating the MAC system, which is going to cause the red blood cell to just lyse right there in the capillary, right there in the artery, or is it going to go ahead and be destroyed in the spleen a little bit more delicately, we might say. So that is the location is another way of characterizing the type of anemia. So we've talked about some of this before, but just to go back into it, if you're a red blood cell, you do not do aerobic respiration, which means you need a way to regenerate. You make NADH, but that means you used up all of your NAD+. So you have to regenerate it. Normally you regenerate at the electron transport chain. You don't do that in red blood cell. You don't even have a mitochondria. So instead you use lactate dehydrogenase to regenerate it, which means we have tons of lactate dehydrogenase in red blood cells. So when they die and they spill their guts everywhere, LDH is going to go up. Similarly, they're going to die and spill their guts. And what are red blood cells if not just large bags of hemoglobin? So they're going to spill their hemoglobin out into the plasma. And some of the hemoglobin gets converted into, the heme gets converted to bilirubin. And sometimes we have this protein called haptoglobin, which just snatches up the free globin monomers. And so if the haptoglobin is binding onto the hemoglobin proteins, that means that our free concentration of haptoglobin goes down. But haptoglobin, as I'm saying here, goes up in inflammation in general. So while it might be sensitive for hemolysis, it is not specific for hemolysis. All right, so we're spilling our guts. We got lots of heme going everywhere. It means we've got lots of bilirubin, specifically indirect, unconjugated. This could cause jaundice. Now, abdominal pain and back pain, the hemoglobin will bind onto and consume nitric oxide. Nitric oxide is a vasodilator. It's a smooth muscle relaxant. And so if you consume all of this, then your muscles are just going to randomly contract. This causes back muscle spasms, which are associated with pain. That also causes abdominal pain, but the abdominal pain might be like extra bad because also splenomegaly is going to be a feature here. You need nitric oxide for the vasodilation of the penis, so erectile dysfunction is going to be a thing. Also, the smooth muscle relaxation and contraction is going to be an important, highly regulated dance for something like peristalsis. So dysphagia, difficulty swallowing is also going to be an issue. There's lots of different types of, maybe not lots, mainly we have cholesterol, gallbladder stones. But you can also, if you have too much bilirubin in the blood, which you would have if you have tons of hemolysis, you can also get what's called a pigment stone, which is really just lots of bilirubin, which accumulates and precipitates. Too much hemoglobin might eventually just get passed into the urine, so hemoglobin or urea. Often, though, a urine dipstick cannot differentiate between myoglobin and hemoglobin. So sometimes it's unclear if it's rhabdomyolysis. You might have to, look at other features like is there jaundice, are they anemic to differentiate these two. And your red blood cells dying, they're spilling out their guts, spilling out their hemoglobin. So we know that the globin things proteins get captured by the haptoglobin, but then the heme gets recycled, and then the iron gets evacuated. The iron is going to get grabbed by ferritin. If there's too much ferritin grabbing too much iron, it might clump together and becomes insoluble. It becomes something called hemosiderin. The hemosiderin can deposit in various like joints and tissues, but it can also go into the tubular cells of the kidneys, and eventually, put very scientifically, it can just go you pee pee. Your hemosiderin can be in the urine, hemosideruria. So as you can probably imagine, intravascular hemolysis is going to be a little bit messier than extravascular. The spleen is, it's late, and I don't have a great metaphor, but the spleen is like ready. Its job is to kill people in a very, precise and delicate way, and so it has a specific mechanism ready for cleanup. Intravascular hemolysis is like, I don't know, killing somebody in the street, and then it's like, like maybe the spleen is like a careful assassin that it kills somebody, and then it has like all of the plastic to roll them up or something, while the intravascular hemolysis just dies, and then their body's just in the street, and I think I made my point. So we're going to have more hemoglobinuria, more hemosideruria, for intravascular, less for extravascular. Same that the haptoglobin levels are going to be more diminished in an intravascular versus extravascular hemolysis situation. All right, so just going a little bit more in the spleen. So in the red pulp of the spleen, these red blood cells will eventually just empty, this blood vessel just ends, and they just go into this empty circulation, and they go to this sinusoid area. We might also call this the splenic cords. We might call this the cords of Billy-Roth. But effectively, the red blood cells then have to squeeze into these new capillary beds called sinusoids. And I kind of imagine it like kids doing the limbo. So kids can do the limbo. A young, healthy red blood cell can do the limbo. They can make it through no problem. But an old red blood cell or a defective, crappy red blood cell, I think of like the scene from Midsommar where it's just like, let's just take care of the old people. Let's take care of the old red blood cells that are older than 120 days. That is the job of the spleen. So anybody that has difficulty making it through, that's where these macrophages are going to come in and destroy them. There's just another picture over here. So for the most part, this is old red blood cells, but for, I guess, the purposes of our hemolytic anemia, we can think that there might be a lot of defective red blood cells that are just going to get, euthanized. So extrinsic causes, autoimmune, microangiopathic, macroangiopathic, small vessels, large vessels, and infections like we talked about. So autoimmune antibodies will bind, and they will typically be removed by the spleen. So remember that the spleen, it's hard to grab onto this frog, but if we put this leash on it, it's easier to grab. The leash is the complement protein C3, which macrophages can grab on more easily. And so commonly this will then be in the spleen, where the macrophages can grab onto that antibody C3 and get rid of it. So red blood cells are typically immune from our complement system because they have this CD55, also known as DAF, and CD59, also known as MIRL, which will inhibit complement activation. We see them here, CD55 and CD59. Notice that they are anchored by a GPI, which will come back into play later. Now there's two different types of, this is the healthy red blood cell and no hemolysis. And if you're missing these, then you do have hemolysis, which we'll come back to. But there are two types of autoimmune hemolytic anemias, so-called warm and so-called cold. So the warm one's not really warm, but the cold one is cold. So the warm one is just warm in comparison to the reference point of the cold one. So it's really just normal body temperature. It's an IgG antibody on the red blood cell. Sometimes it's idiopathic, sometimes it's caused by lupus, sometimes it's caused by lymphoma, sometimes leukemia. Medications, methyl-dopa and penicillin can precipitate this autoimmune antibody. And the red blood cells will become spherical, and they lack a central pallor. If it's a spherical red blood cell, it just basically cannot do the limbo when it tries to go through the spleen, and it gets destroyed. And so the spleen is killing so many red blood cells. It just gets engorged. It's too many red blood cells that it has to kill and deal with. And so the spleen will get enlarged, You might even want to take out the spleen because it's killing so many of your red blood cells. So probably for refractory cases, a splenectomy would be necessary. Remember that if you take out the spleen, you might get Howell-Jolly bodies. A Howell-Jolly body is just a red blood cell with a nucleus. Usually the spleen takes care of those, but nope, not if you don't have a spleen, it doesn't. Alternatively, let's just suppress the immune system with glucocorticoids or immunosuppressants, and maybe these antibodies will stop targeting these red blood cells for no good reason. So if we want to detect these antibodies, we can do what's called a Coombs test, also known as a direct antiglobulin test. So here are my patient red blood cells. Maybe there are antibodies, maybe there are not antibodies. And remember, these are IgG antibodies in the case of warm autoimmune hemolytic anemia. So we will then mix these with anti-IgG. So this anti-IgG over here might go ahead and bind, they might bind to this one and bind to this one. And if that was the scenario, we would have them, they would then all clump together. And we would go, aha, so there must have been, antibodies initially on a red blood cell. If they don't clump together, then this picture is misleading. There was actually no of these black antibodies originally. So a negative Coombs test and a positive Coombs test. So Coombs test is the DAT, direct antiglobulin test, but you can also run an indirect antiglobulin test. So again, in this one, you're taking the patient's red blood cells, which already have the antibodies on them. You're adding the anti-IgG, which binds to IgG Fc regions, and then you look for the agglutination. If there's agglutination, you know that the person has an autoimmune hemolytic anemia. And the question here is just, do they have the hemolytic anemia? Now, in the indirect test, we're not taking the patient's red blood cells, we're just taking their antibodies. And we're actually putting them with dummy red blood cells and the anti-IgG antibody. And I want to see if there's agglutination or not. This is testing for a very similar thing, but also a little bit different. I just now want to see, are there antibodies in the serum period? Maybe these antibodies actually wouldn't even be interacting with my red blood cells. Maybe I want to see if I want to give you a donation of type A negative blood or something. And I want to see if you have maybe this is my A negative red blood cell. And this is just one thing that I can think of off the top of my head. There might be several reasons you would do this, but in this case, we would see if you have antibodies to the A negative antibody. So this is just the indirect Coombs test, and you're testing the plasma for the antibody rather than the antibody already on the red blood cell. So that was warm. Now we have the cold. The cold is going to be in the extremities, and instead of an IgG antibody, it's an IgM antibody. And the IgM, remember, is really good at fixing the complement, specifically because the complement has to be cross-linked so one C1 protein has to bind to two antibodies. Well, that's really easy on the IgM because it's a pentamer. So the IgM is really good at fixing the complement. So it activates C1, which activates a bunch of other stuff, which activates C3. C3 can then activate other things, but it also, again, acts as that handle, that frog leash that we saw earlier. So the IgM, though, does fall off in the torso. Why? Because it's colder in the extremities. That's where they bind. But once you get to the central organs, the IgM falls off. But the C3 stays on for the most part. So if we wanted to run a Coombs test, a direct antiglobulin test, we wouldn't check for the antibodies because the IgM will have fallen off at that point, but we would check to see if the C3 is there. What causes cold autoimmune hemolytic anemia? Mycoplasma pneumonia, infectious mononucleosis, also known as the Epstein-Barr virus, and then chronic lymphocytic leukemia. The cure for this, just immunosuppressants or just stay warm, really. Probably staying warm is a little bit easier because, again, it's going to be in the peripheries and the extremities where it's cold is going to precipitate this autoimmune reaction. Okay, so this is, I don't really know the name for this, but let's call this MAHA, right? Well, didn't we see another MAHA? Yeah, the other MAHA is microangiopathic hemolytic anemia. And this is macroangiopathic hemolytic anemia. Micro versus macro. The other one was in small blood vessels and capillaries. This is in larger areas, probably most commonly a mechanical heart valve and aortic stenosis. So the red blood cells are just flying past, really quickly, and it's all about running into stiff, hard things. In aortic stenosis, you have a really stiff valve, and if you have a mechanical valve, well, you know what? There's probably some metal or something in there. That's probably pretty hard too. So these stiff walls, running into them is going to cause the red blood cells to, for lack of a better way to put it, they're going to explode, and it's going to cause a hemolytic anemia. So that's the macro, and then we have the micro, which we've talked about previously. Idiopathic thrombocytopenia purpura, and then the the ITP, TTP, and then the disseminated intravascular. Again, it's coagulation, but I like to think of it as clotting. Why? Because it's not just coagulation factors, it's clotting. It shows that it's coagulation plus platelets. Platelets are a thing here as well. And so what you have is, so this is, I guess, a normal, healthy capillary. And in this case, you have a little bit of a thrombus. So thrombus, and it doesn't say here, but you know what? There's a thrombus there as well. And they try to run past, and they get sheared off a little bit, and you get these schistocytes. So the schistocytes are going to be very telling for this. And here's a schistocyte, here's a schistocyte, here's a schistocyte. Again, they're trying to run through, and they basically get cut in half, or cut in, a quarter of them gets cleaved off. So this would lead to a hemolytic anemia as well. And then lastly, we have malaria and babesia are probably the two major pathogens which could cause a hemolytic anemia. You get rings with babesia, and you also get rings, but they're trophocyte rings with malaria, so slightly different, and stuff that we'll go into a lot more detail on in the bacteria and pathogen parasite section. So that was extrinsic. Let's look at intrinsic. So these are mostly genetic defects of the red blood cells themselves that make them deformed, which often makes the spleen want to take them out of commission. So hereditary spherocytosis. So SP for spherocytosis. You have spherical red blood cells, and it's usually due to defective cytoskeletal proteins. The main one is spectrin. It could be a band protein, or it could be ankyrin. Here's my band protein, here's my ankyrin. How does all of this work? I don't know, it doesn't matter. Spectrin, SP, is probably the main one. The idea is, so this is important to have the cytoskeletal connect to the membrane, is important to give it its nice, biconcave shape. And if you are lacking any of these three proteins, it is going to cause the red blood cell to change its shape to be spherical. And if you have this deformed spherical membrane, you will be taken out in the spleen extravascular hemolysis, because at the cords of Biller-Roth and the sinusoids of the red pulp of the spleen, you can't do the limbo, and so the red blood cell will get destroyed. Like we saw in Cooley's anemia, which is beta thalassemia major, like we saw in iron deficiencies, we will have higher variability in red blood cell size, which is just to say that the RDW is a little bit higher here than it would be in a wild type healthy cell. Also, the mean corpuscular hemoglobin concentration goes up, but that might be less important. So because they're spherical, there's a reason, there's a purpose to the shape that they have. And so the spherical shape, it might sound good to be spherical, but it's actually much less stable, and it's more fragile, so it's more likely to lyse. And something that makes a red blood cell lyse is if you put it in a hypotonic, watery solution. Why? Because water will want to rush into to osmosis, and like we can see in this one, too much water rushing in might cause it to swell and explode. Now, most cells will eventually explode if you put them in too hypotonic of a solution, but I guess the idea is that they are more fragile, and so they will lyse more quickly than the other one. So here's our normal situation, sodium chloride concentration. So I'm slowly raising the concentration, and look, this is where my red blood cells should be. This is my red blood cells, and this is my plasma. They're staying strong, and right now they start to die a little bit. Too much, it's too watery, water's rushing in, it's killing them, and then they're spilling their red hemoglobin guts up here. So it's getting more red and more red and more red, and okay, pretty much here it seems like homogeneous, that most of them have died at that point. Okay, what happens in this case, though, is that they're more fragile. I've barely raised the hypotonicity, how watery the solution is at all, but notice in this case, they're already dying, and it's only 0.65. Here, they didn't start to die till 0.5, but again, the point is that they're more fragile. All right, paroxysmal nocturnal hemoglobinuria, PNH. So we saw this picture earlier. CD55 and CD59 say, "Hey, cool it complement," right? The C3 can come in and it's not allowed to activate the complement system. So there's no hemolysis. Good. We don't want hemolysis on our own red blood cells. But sometimes people just over the course of their life they acquire mutation in the hematopoietic stem cells. Specifically the gene that codes for the GPI anchor, which is necessary to bind the protein to the membrane. And so if I don't have this, I lose these inhibitory complement proteins. And so then the complements just go nuts, complement activation, and they kill all of these red blood cells. It might also affect platelets and white blood cells too, so it actually might be a pancytopenia. One way you can diagnose this is through a flow cytometry. So a flow cytometry is I would put like a fluorescent antibody that would bind here, and so it's going to fluoresce red right there. And so I would put this in a machine and it shows red fluorescence, and that tells me, okay, it's red fluorescence. It must mean that my fluorescent antibody bound to CD59, and here I would have no fluorescence, and that must tell me that I must be missing something here because I didn't have an antibody that fluoresced that was bound to my cell. So paroxysmal just means that it's intermittent. It comes and goes. Now it comes a little bit more at night. So this is actually debatable, but let's just go ahead and say it comes more at night. The idea here is that at night you're hypoventilating, and this shallow breathing might increase the amount of CO2. So you're not breathing out as much, so the CO2 goes up. And we all learned in undergraduate intro chemistry that Le Chatelier says if that goes up, this is an equilibrium, so it's going to push this to the right. So the hemoglobin concentration goes, not the hemoglobin, the hydronium H plus concentration goes up. So this lowering of the pH causes this respiratory acidosis, is actually going to stimulate the complement system, which is why this might be worse at night. The red blood cells lysing, as we see here, means they're spilling their guts, as we can see here. This is going to, it's intravascular hemolysis, which we said is the worst one. That free plasma hemoglobin is particularly thrombogenic. So you're getting this specifically because we have the hemoglobin, this is going to be released into the bloodstream. This might cause jaundice, and if we have too much of this, some of it might be going into the urine. On top of this, though, why I got confused a little bit is this should also say thrombus. So these are two separate things. You're going to have hemoglobin in the urine, and then you're also going to have thrombus. So the thrombus here is because the plasma hemoglobin is also thrombogenic. On top of that, we said that this might be pancytopenia because the same thing, the CD55 and CD59 that are working for the red blood cell might also work for the platelets. So platelets will be destroyed as well. When the platelets are destroyed, the alpha and dense granules get released, and these secretions are going to activate the GP2 and GP3, causing platelet aggregation, which might just form a thrombus. So eculizumab, which I'm sure I'm mispronouncing, is going to be an anti-complement protein 5. So if we think about this, complement protein 5 to 9 are responsible for the MAC complex, which causes the intravascular hemolysis, the osmosis, the flowing in of water in the red blood cell. But remember, we still have C3 bound. So the MAC over here is inhibited, but I still have C3. So these will still go to the spleen, and then remember, this is the frog with the leash on it. The leash is the C3. The macrophages in the spleen at the cords of biliroth still might grab onto these red blood cells and destroy them. So we still might have some extravascular. So it works, but doesn't work perfectly. G6PD, we saw this in the biochem thing. This is X-linked. Often it's in people of African, Middle Eastern, and Mediterranean descent. And like we see in sickle cell, like we see in thalassemias, this might have a protective effect against malaria. So glucose can obviously go down to become pyruvate. Glucose, phosphate can go ahead and become glycogen, but it can also go through the pentose phosphate pathway to make, among other things, NADPH. NADPH can help make glutathione. Glutathione reduces reactive oxygen species. If I have a deficiency of this, that means I'm going to have more reactive oxygen species, which might cause my red blood cells to become sick and to die. Now, this will become exacerbated and triggered, extra reactive oxygen species if I have infections, if I'm taking certain drugs like sulfa drugs or any sort of antimalarial drugs, anything that ends in quin, primaquin is our example here, and fava beans, which made me think of Hannibal Lecter. So characteristic of this, this comes in other cells, but in other conditions, but it's really, I would say it's mostly in G6PD, is our, let's start with Heinz bodies. So we might have these Heinz bodies here. And the Heinz body with this little basophilic remnant on the side, when this gets into the spleen, the macrophages will try, because it's on the periphery, they will try to take they won't destroy the entire cell. They might just destroy this little bit right there. And so now, as a result of the Heinz bodies, we get these bite cells. And it's just a little bite has been taken out of the red blood cell by the macrophages. And again, this is the deficient enzyme here. So pyruvate kinase deficiency, red blood cells rely on glycolysis for energy. And if you don't have ATP, you can't generate. So pyruvate kinase is the last step, the last enzyme in glycolysis. So you're going to have insufficient energy production. And if you don't have enough energy, you can't maintain your membrane. And if you don't have a membrane, you cannot do the limbo through the corzabilirath, which means the spleen is going to eat you up, which is extravascular hemolysis. It's really common to be seen in newborns. Sickle cell anemia. So again, protective against malaria. People of African or Middle Eastern descent. Vaso-occlusions cause episodes of extreme pain. Could cause stroke due to difficulty for the sickled cells to get through the smaller microvasculature. Splenomegaly is the spleen is just trying to, all of these sickled red blood cells have a hard time getting through the corzabilirath. And actually, this can cause destruction of the spleen because it gets just too large. Severe fatigue because you're not getting oxygen delivery. And you can treat this with hydroxyurea because it's the hemoglobin A that's defective. But if you could make fetal hemoglobin, not hemoglobin, I spoke correctly. Hemoglobin A is defective because we have a deficient beta globin gene, but the hemoglobin F actually still works quite well. The problem is that we just have like 0.1% production of hemoglobin F, but hydroxyurea can increase the concentration so that it actually might be able to, deliver a little bit more of the load, and our oxygen delivery can be closer to normal. So one allele, the heterozygote advantage, might be protective against sickle cell, and you might be, normal-ish because you've got some normal red blood cells and some sickle ones, and it kind of maybe balances out. The homozygotes would be obviously the particularly bad scenario where you have severe sickling. So hemoglobin A, so this is specifically the beta globin gene, our sixth amino acid. The glutamate is converted to a valine. Valine is hydrophobic, and all of these hydrophobic things stick together, hence the sickling. And at low oxygen and acidic conditions is where the sickle cells will precipitate together and aggregate. So at low oxygen and acidic conditions, this disease is going to be worse. B19 parvovirus, so this is going to get into the bone marrow and replicate inside of, so this is our red blood cell precursor. This is going to get inside and replicate there. So normal people, maybe we'll get a little sick, often kids, like mild anemia, but nothing too bad. Because we don't, we're having a little bit of hard time with erythropoiesis, but, our red blood cells last for 120 days and we're fine. We have plenty of red blood cells. But if somebody has a chronic hemolysis condition, if they have sickle cell, hereditary spherocytosis, any of the thalassemias, especially thalassemia majors, G6PD, especially if you have one of these triggers, you're eating a lot of fava beans or paroxysmal nocturnal hemoglobinuria. These guys, their red blood cells are dying all the time. They need every bit of erythropoiesis they can get. So if they have a B19 parvovirus infection, they are really screwed. They're in bad shape, and this can lead to an aplastic crisis, which is not good. All right, last one. Home stretch. Macrocytic anemias, as you can guess, has to do with anemia where the red blood cells are too large. This falls into two further categories, megaloblastic and non-megaloblastic. So megaloblastic, really, I guess there's two things. So the reason that the cells are getting larger in this case is because there's abnormal DNA synthesis. So that's one thing to know. So if there's not appropriate DNA synthesis, they can't divide as much as they should. And it's every time a red blood cell precursor divides, it gets smaller and smaller and smaller until it's ready to go. It's a fully mature red blood cell, and then it gets pushed out. But if they don't have enough of the DNA precursors, they can't do synthesis, they can't do replication, and so that makes them too large. So that is a feature of megaloblastic, despite the fact that the non-megaloblastic is also large, but it's not anything to do with DNA synthesis. And then two is they have these hyper-segmented neutrophils. This is really for the same reason. The neutrophils or precursors also have issues with cell division. So a normal neutrophil should have this like characteristic three-lobed nucleus. And in this case, this is the not normal megaloblastic one. There's like 9 different lobes of the nucleus there. So if you see hypersegmented neutrophil, boom, bingo, this is megaloblastic. That has to do with the DNA synthesis. Not a lot to say about the non-megaloblastic, again, just normal neutrophils and nothing to do with DNA synthesis. These are going to be less common than the megaloblastic ones. So probably the main way you're going to have a megaloblastic macrocytic anemia is if you have a folate, B9, or cobalamin B12 deficiency. And again, I told you guys, you're never going to escape this particular image, this slide. This is going to come forever. How is this working? Folic acid is necessary to generate 5,10-methylene THF, which is really just going to give a methyl to a uracil, which turns it into a thymine. In other words, you need folate to make purines, and you need purines to do division, and you need division to become a smaller red blood cell that's mature. And if you don't do that, you're going to be a large megaloblastic red blood cell. On the other hand, if I don't have B12, you know what? It's the exact same story. I'm going to have diminished purine synthesis. So differentiating these two, I think, is going to be important. So B12 also plays a role in the conversion of methylmalonic acid to succinyl-CoA. So if I have a B9 deficiency, B9 is folate. So if I have a B9 deficiency, I'm only going to have homocysteine levels up. So note that if I didn't have B9, I would not be able to do this reaction, which means I would not be able to convert homocysteine to methionine, which is why homocysteine is just going to build up. So homocysteine levels are higher, but it has nothing to do with this reaction over here. So only homocysteine levels are up. On the other hand, if we have a B12 deficiency, well, if I have a B12 deficiency over here, it's the same thing. My homocysteine levels are going to go up because I cannot convert it into methionine. But B12 we're seeing also has a role over here. We cannot generate succinyl-CoA, which means the methylmalonic levels will go up. So for B12 deficiency, you are going to have both homocysteine and methylmalonic acid build up. So it's an important way that they might differentiate the two. Actually, we'll come back to orotic acid in a second. Let's just talk a little bit more about B9 and B12. So B12, a lot of people think, so let's say that you were a vegetarian or a vegan. Maybe you would have a harder time getting B12 into your body. Well, your body has way more stores. You have tons of B12 stores for years. You would have to be a vegetarian and vegan for years, not take a single supplement, and just eat very, very specific, types of vegan pancakes. And then maybe eventually your B12 would go down and you might become anemic, megaloblastic anemic specifically. If it's a diet issue, it's more likely that it would be a B9. B9 is going to be, griefy. It's very late here. It's going to be leafy green vegetables, and that might run out in a couple weeks. So B12, you have years of stores. B9, you only have a couple weeks of stores. So could be B9 due to a poor diet. More than likely, if it's B12, it's something called pernicious anemia. So you guys might recall from the MCAT, you have parietal cells in your stomach, which generate hydrochloric acid, but they also produce something called intrinsic factor. When you take in B12, B12 itself is not very easily absorbed in the duodenum. It has to be complexed to intrinsic factor produced by the parietal cells in the stomach, and then it can go and be absorbed into your through your duodenum, only with the intrinsic factor. But pernicious anemia is you have autoimmune attack of these parietal cells, which destroys the intrinsic factor, which means the B12 will not be absorbed. Alternatively, maybe you have celiac disease. Maybe you had a gastric bypass and you're bypassing your duodenum. There could be various other reasons why you're having difficult with absorption, but probably the most likely is the B12 pernicious anemia reason. All right, so for a very similar reason, erotic aciduria is going to cause megaloblastic anemia. So this is the purine synthesis pathway. And notice that one of these steps is orotic acid being converted to uracil monophosphate. And you need uracil monophosphate synthase. But if you have a deficiency in this enzyme, you cannot generate this. And if you can't generate this, you have a hard time generating your thymine. And this is going to be really a very similar clinical presentation as not having enough folate, not having enough B12. Many chemotherapy drugs also, their role is to either stop the pyrimidine or the purine pathway. So any of these drugs would do a very similar thing. And so for the non-megaloblastic anemias, the DNA synthesis is normal, but the red blood cells are still big. The two big ones to know are the liver disease and alcoholism that might cause this. And if you couldn't tell, I'm pretty tired and I kind of pooped out. So this last slide is me giving up. This is I'm tired. I'm going to bed. So I hope this was helpful. And good luck to everybody on the test.